you. So all those people who are actually not interested, guys, please remember, abstain yourself from doing these things. Okay, let others study at least. Question number 1 says, a pregnant lady at term. So usually term is between 37 weeks till 41 completed weeks of gestation or pregnancy. So this pregnant lady at term delivered via normal vaginal delivery, and the post-operative period was uneventful. That means there were no other complications in the post-operative period. The next day, she complained of extensive bleeding per vagina. Which among the following type of placenta can be implicated as a cause? So first of all, let's come to a provisional diagnosis. What do you think is a provisional diagnosis in this condition? Definitely, if a pregnant female bleeds, that means if there is a hemorrhage in a pregnant female, two things can be thought of. First, if the bleed is between 28 weeks of gestation till delivery, it is called as antepartum hemorrhage. Whereas if any bleed is after delivery, that would be called as postpartum hemorrhage, right? I hope all of you are quite aware. Antepartum hemorrhage can be of 3 types actually. It can be either placenta previa, it can be vasa previa, where there would be painless bleeding in the patient, and the third thing would be abruptio placentae, where there would be painful bleeding in the patient. Whereas if I talk about PPH or postpartum hemorrhage, it is subclassified into 2 types. Primary PPH, when the bleeding would occur within 24 hours of delivery, and secondary PPH, when the bleeding would occur after 24 hours of delivery until 12 weeks. Okay, from 24 hours of delivery until 12 weeks, it is considered as secondary PPH. So here, the pregnant patient delivered via normal vaginal delivery, and in post-op period, there was no complication. But the next day, this is important, the next day, that means after 24 hours usually, she complained of extensive bleeding per vagina. So therefore, the provisional diagnosis becomes secondary PPH, that is secondary postpartum hemorrhage. And what is the most common cause of secondary postpartum hemorrhage? It is usually retained tissues, right? For primary postpartum hemorrhage, the most common cause is usually atonic uterus. Out of the 4 T's that we have for PPH, the most common one is atonic uterus. Second is trauma or injuries to the genital tract. Third is thrombin deficiency or any type of coagulopathy. And fourth is retained tissues. So for primary PPH, most common cause atonic uterus. For secondary PPH, most common cause retained tissues, right? And which type of placenta can lead to retained tissues? Let's see the types of placenta. These are the images. The first one that you can see in the image over here is a filamentous insertion. So usually what happens, the umbilical cord will go onto the placenta and would insert somewhere in the middle. Okay, so that would be called as a normal insertion. But here you can see the umbilical cord of the placenta will enter the placenta and is attached to the membranes, the fetal membranes, and it gets separated even before entering the placenta, right? So definitely whenever there would be premature rupture of membranes or there would be rupture of membranes, in this what will happen, there would be stretch on this membranes, and that will also lead to rupture of these vessels, and that can cause bleeding from the fetus or the mother. That can lead to bleeding from the fetus, and that is called as vasa previa, and this condition is 50% times fatal. In 50% cases, usually the fetus die in this case. So if they ask you in cases of filamentous insertion, what can be the pathology? The answer should be vasa previa would be associated with filamentous insertion type of placenta. The next one that we have, it is the battledore or the marginal placenta. Here the umbilical cord will enter the placenta at the margins, and therefore it is called as marginal insertion or a battledore placenta. So by door you can remember it. Okay, so next one is a bilobe placenta. By the name it is evident. Then we have circumvallate and circummarginate placenta. In both of these, usually what happens, the membranes would double up on the margins or the periphery, right? In circumvallate placenta, there would be a valve-like structure in between, whereas in circummarginate placenta, there would be thin margin of the fetal membranes, okay, and the placenta would not be valve-like or it would not be depressed. Both of these types of placenta are associated with intrauterine growth restriction in the fetus, IUGR. Whereas the last type of placenta, that is substantiate lobe, also called as the accessory lobe. So what happens usually during the 3rd stage of labor, that means during the delivery of placenta, this main part of the placenta is removed. But as we are not sure if there is also accessory lobe for the placenta, therefore we usually insert our hand and try to clean the uterus, right? But if that is not done and this lobe of the placenta, that is an accessory or a substantiate lobe of placenta, is retained behind the uterus, that would lead to a secondary PPH in this case, right? This will lead to a secondary PPH, that is secondary postpartum hemorrhage, right? Hemorrhage after 24 hours of delivery. So please remember here the answer should be option C. Substantiate or accessory lobe of the placenta is the common cause of secondary postpartum hemorrhage. Okay. I hope this was easy. Moving further to question number 2 now. It says a 20-year-old with heavy bleeding per vaginum since 3 days comes to you. Hemoglobin shows 6.4 grams per deciliter. So what is the normal value of hemoglobin in a female? So it should be 12 to 14 grams per deciliter, right? Please remember, it should be 12 to 14 grams per deciliter. It is considered as anemia when the hemoglobin level is less than 12 grams per deciliter. But in Indian females, as we know, usually the hemoglobin levels are low in Indian females as compared to the females worldwide. So in Indian females, the cutoff for anemia is usually hemoglobin level less than 11 grams per deciliter. And in pregnancy, the hemoglobin levels will drop further. Therefore, in pregnancy, the cutoff would be less than 10 grams per deciliter. So definitely the patient is having anemia in this case. Along with that, this anemia is severe because when the hemoglobin level is less than 7 grams per deciliter, it is considered as severe anemia. And in this condition, usually blood transfusion is indicated in the patient, right? In any patient, irrespective of pregnancy. So in this case, the patient is complaining of heavy bleeding per vaginum, 3 days, and hemoglobin shows 6.4 gram per deciliter. What is the first test to be done in this case? What is the first case to be done? So please remember the first test to be performed in this case should always and always be option B, UPT. That is your urine pregnancy test. Because in a young female, the first thing that you will suspect is pregnancy, right? If she is complaining of heavy bleeding per vaginum or abdominal pain, the first thing that you usually suspect, that is pregnancy. And therefore, the first thing to rule out pregnancy is a very handy test, that is urine pregnancy test. Okay. So you would say, why not a transvaginal scan? It would be far more better as compared to a urine pregnancy test. So please remember, definitely transvaginal scan or ultrasound can be preferred, but it will not be the first test to be performed, right? Most of the times, transvaginal scan is not available in the emergencies, or even in OPDs, the patients get a date after 2 or 3 months. So definitely it is not a very feasible method to be done. Progesterone challenge test is anyways not done to diagnose pregnancy. It is rather for ovulation. Whereas beta HCG radioimmunoassay, definitely it is one of the best tests to diagnose pregnancy. But why it is not done? Again, for the same reason, it is not feasible and it would not be available in all the places. Therefore, it would not be our first choice. And they have asked you the first test to be done in this case. Therefore, it should be your urine pregnancy test in this condition, right? If they ask you which is the best biochemical test to diagnose pregnancy, please answer in the chat box. The best biochemical test to diagnose pregnancy would be. Please let me know in the chat box. Yes, beta HCG. Beta HCG is also assessed with a urine pregnancy test. It is also assessed with a radioimmunoassay. It is also assessed on a fluorescent immunoassay, which would be the best one. There are multiple things. Beta HCG is assessed in each and every test to diagnose a pregnancy. The best biochemical test out of all would be a fluorescent immunoassay, followed by a radioimmunoassay. In both of these, we will definitely check for the beta HCG levels, right? What is the best test to diagnose pregnancy? So if they ask you the best test or the gold standard test to diagnose pregnancy, so in this condition, as I've always told you, best test or gold standard test, they may not be practical always, okay? But they are the best test to diagnose any particular condition. So it should always be laparoscopy. So please remember, as we know, laparoscopy, nobody would perform a laparoscopy to diagnose only pregnancy, right? Ultrasound is a far superior method than it. But if they ask you the best test or the gold standard test, the answer would remain laparoscopy in this condition. Doubling of SCG. So please remember, usually the levels of SCG increase in pregnancy, right? Till almost the mid second trimester, the levels of SCG usually increase. In cases of intrauterine pregnancy, doubling of SCG would occur within a period of, very good. In cases of intrauterine pregnancy, doubling of SCG occurs within a period of 48 hours, okay? Whereas in cases of ectopic pregnancy, please remember, in cases of ectopic pregnancy, doubling of SCG usually occurs in a period of 5 to 7 days. So doubling of HCG within 48 hours, intrauterine pregnancy. Doubling of HCG within 5 to 7 days, ectopic pregnancy. If the HCG values keep on decreasing, that is suggestive of abortion then. Okay, that is suggestive of rather abortion, right? So again, I would request you to abstain from doing these things. Okay, all of you are adults, you're enough mature, you understand the seriousness of the situation, right? Laparoscopy, please remember, see, laparoscopy is the best of the gold standard test. Nothing, no other test would be more superior than laparoscopy. Okay, but it is not practical to actually perform a laparoscopy to diagnose something like pregnancy, which can also be done on ultrasound, right? So ultrasound is a non-invasive test. So why you need to go to an invasive test like laparoscopy, where the patient would, okay, so where, just a minute, I'll share it again. So yeah, thank you for letting me know the name. Okay, I'll go a little slow, no worries. Let me know if you're having any issues to catch up with the pace or catch up with the speed. Okay, so let me stop once and then again I'll share it. That would be much better. Okay, just a minute. Let me forget this because there are problems with this one. So now just let me know if the screen is visible once it starts sharing. Yeah, I hope it is visible now. Shall I move further? Yeah, okay, guys. So question number 3, guys. I hope your doubts are clear for the previous question now. No doubts for the previous one. Question number 3 says a primi gravida. Primi, that means for the first time. Gravida means pregnancy. So that means she has conceived or she is pregnant for the first time. A primi gravida comes for a routine antenatal care visit, that is ANC visit, at 22 weeks of gestation. Which of the following signs would you not expect? So I hope all of you are quite aware of the signs which are seen in the first trimester or second trimester of pregnancy, because they are helpful you to diagnose the gestational age also and the well-being of the fetus as well. Okay, there are different signs in first as well as second trimester that we use for clinical examination in a pregnant patient, right? So let's rule it out one by one. First of all, please remember this female has come to me at 22 weeks of gestation. That means in the second trimester. That means all the below given signs are seen in second trimester except for. So let's rule it out one by one. Option A says lightening. So what do we mean by lightening? So all of you are quite aware that during pregnancy, the size of the uterus increases, right? And once it comes around 36 weeks, it comes at the level of the xiphisternum. And when it comes at the level of xiphisternum, it will compress the diaphragm and that will cause respiratory distress in the patient. But after 36 weeks, near to term, usually at term, what happens? The fetal head will descend down into the pelvis. As the fetal head goes down into the pelvis, the size of the uterus decreases. Okay, the size of the uterus decreases from the xiphisternum. It goes into the flanks usually, right? And now the patient would not experience this respiratory distress, and the patient feels light, and that is called as lightening. So usually lightening would be seen where? After 36 weeks of gestation, that means in the third trimester. So definitely we have got our answer. It is not the sign of second trimester. Let's check for the other ones. Option B says Braxton-Hicks contractions. I hope all of you are quite aware of Braxton-Hicks contractions. Sometimes they are also termed as false labor, right? So here the patient will experience abdominal pains which will resemble like a true labor, but these are not true labor pains because these Braxton-Hicks contractions or false labor, they appear around 16 to 18 weeks of gestation. They appear around 16 to 18 weeks. That means in the second trimester of pregnancy. So how to differentiate it from true labor? There are two important things. First of all, please remember these contractions would be irregular. Okay, true labor contractions are regular, but these contractions would be irregular. First thing. And secondly, these contractions would be less intense. Okay, whereas as we know in true labor, those contractions are really, really intense. Here, the contractions would be less intense. The patient would not experience much pain. There would be a mild pain. Okay. So these are the two important things. So again, Braxton-Hicks contraction is a sign seen in second trimester of pregnancy. Option C says quickening and ballotment. So quickening is what? Please remember when the mother starts experiencing the fetal movements. Okay. When the mother will experience fetal movements, that is called as quickening. And when is quickening seen? So it is seen around 22 to 24 weeks of gestation. That means again in the second trimester, right? So quickening is seen in 22 to 24 weeks of gestation, and also ballotment is felt at the same time. So usually we have two types of ballotment. One is the internal ballotment and second is the external ballotment. What do we mean by internal ballotment? It is usually seen at 16 to 18 weeks. Okay, when we perform a per vaginal examination and we feel the head of the fetus. Okay, if we push the head back, then it will again come and hit your fingers. This is called as internal ballotment. Okay, whereas external ballotment is what? When we'll actually try to palpate the lower segment of the uterus, we can just shift the head from one side to the other side. Okay, this is called as external ballotment. And external ballotment comes at around 22 to 24 weeks. So whether internal ballotment or external ballotment, both are seen in cases of second trimester. That is internal at 16 to 18, whereas external ballotment at 22 to 24 weeks. Whereas the last one is cloasma. Cloasma is also called as melasma, right? Also termed as mask in pregnancy. So it is due to the increased levels of estrogen, progesterone, and beta Hcg during pregnancy. That will cause what? That will cause activation of the melanocytes. When the activation of melanocytes occur, that will lead to hyperpigmentation of skin. And this hyperpigmentation of brownish discoloration of skin is usually seen over the cheeks or the bridge of the nose. Okay, over here. Okay, please remember that looks like a butterfly rash, but butterfly rash is red in color. This one is usually brownish in color, right? Please remember, and it is usually seen in sun exposed areas, right? So please remember, it is again seen in second trimester of pregnancy around 22 weeks. After 22 weeks, we can see cloasma or melasma in the patient, and it would go off after delivery. Like after 6 to 12 weeks of delivery, it will go off on its own, right? So I hope this was easy. Okay. So here the answer would be option A. Lightening is not a sign of the second trimester, rather it is felt in the third trimester. If I talk about the other signs of first trimester, these are important questions have been asked on these. The first trimester signs of pregnancy, guys. First, they are asking purplish discoloration of vagina. Anybody? Purplish discoloration of vagina. Keep on answering in the chat box, guys. All the questions. If there was a voice lag, so please remember internal ballotment. When I perform a per vaginal examination and will feel the head of the fetus, okay, like this. Okay, if I feel the head of the fetus, I will push the head of the fetus and it will again come back and hit my fingers. This is called as internal ballotment. Whereas external ballotment, for example, this is the lower segment of uterus, okay, and there is the head of the fetus that I can feel over here. If I push it from other side, I can feel it on the other side of my fingers. Okay, so that is called as your external ballotment. So please tell, purplish discoloration of vagina is known as which sign? No. So please remember, some books definitely call both of the signs as similar, but if they ask you specifically, purplish discoloration of vagina is known as the Jacquemus sign. Purplish discoloration of vagina is the Jacquemus sign, whereas here on colposcopy you can see there is a purplish discoloration of the cervix. Okay, so purplish discoloration of cervix is known as the Chadwick sign. C for cervix, C for Chadwick's. Please remember. Okay, sometimes both of them are referred as Chadwick's, but usually purplish discoloration of vagina, it is Jacquemus sign, and bluish or purplish discoloration of cervix is known as the Chadwick sign. Both of these signs usually appears around 6 to 8 weeks of gestation. Then softening of cervix is known as the Goodell sign. So please remember, softening of cervix is known as the Goodell sign. Also appears at around 6 weeks of gestation. Bleeding on expected date of periods. So this bleeding on expected date of periods is actually known as the placental sign. This is known as the placental sign. Whereas implantation bleeding, usually implantation occurs on which day after fertilization? Implantation occurs usually after which day of fertilization? Can anybody tell me? This is important from anatomy as well. Very good. It occurs after, like on the 6th day after fertilization, right? It occurs on the 6th day after fertilization. On that day, if there is bleeding, this is called as the Hartmann's bleeding, a Hartmann sign. Okay, this is known as the Hartmann sign. And last, if we feel pulsatility in the lateral vaginal fornices, this is actually known as the Osiander sign. Pulsatility in the lateral vaginal fornices is known as the Osiander sign. Very good. And this usually is not done. It can be felt around 6 to 8 weeks of gestation when our abdominal and the pelvic fingers or the vaginal fingers can oppose each other. Okay, the abdominal and the vaginal fingers can oppose each other, right? So it is usually known as the Heggar sign. It is not performed. Please remember, it is not performed. But you need to remember the name because it has been asked earlier in questions. I hope you are quite aware of all the first, second, and third trimester signs now, right? In third trimester, usually the fetal heart rate can be heard with the help of a stethoscope or a Doppler. Like with the help of a Doppler, you can hear the fetal heart rate as early as 10 weeks also. Okay, please remember that. Question number 4 now, guys. A 28-year-old G2P1. G means gravida. That means how many times she was pregnant. And P means parity. That means how many times the pregnancy went beyond 20 weeks of gestation. I'll explain this to you. We have the obstetric score question. So just remain a 28-year-old woman, G2P1 woman, presents to the antenatal clinic at 24 weeks of gestation for a routine antenatal checkup. Ultrasound shows a normal for gestational age fetus in a frank breech position with no other abnormalities. What is the next best step in the management? What should be your answer? I hope this was the easiest one out of all. Okay, so she has come for a routine examination in the second trimester of her pregnancy, that is around 24 weeks of her pregnancy, right? Ultrasound was performed. It showed normal for gestational age fetus and no other abnormalities. So, and the patient, the fetus is usually in the frank breech position. What do we mean by frank breech? When the upper limbs are usually flexed, but the lower limbs are extended. This is called as the frank breech or the extended breech, which is the most common type of breech, right? So there's like, what should we do for this frank breech position right now in the second trimester? So please remember, nothing should be done for this frank breech right now. Why? So please remember, this frank breech would, until term, like around 37 to 38 weeks of pregnancy, this frank breech can become a normal cephalic presentation also, right? Because the amniotic fluid volume will increase and there would be rotation of the fetus, and that will turn this frank breech in a normal cephalic presentation as well till term. If please remember, if till 35 weeks or 36 weeks, this frank breech does not turn into a normal cephalic presentation, then at 36 weeks, usually we can perform an external cephalic version, but it is not recommended in the second trimester as of now. Okay, so this would be ruled out easily. Modified biophysical profile. So please remember, as I hope all of you are quite aware, that biophysical profile or modified biophysical profile are usually done to assess the fetal well-being. Okay, it is done for fetal surveillance. Okay, is the fetus well or not? It is usually done after 32 weeks of pregnancy. Definitely, it can be done after 24 weeks also, but it is usually recommended in the third trimester after 32 weeks of pregnancy, until and unless there are no other high-risk conditions in the mother, or there are no as such congenital abnormalities in the fetus. Okay, if there is a high-risk pregnancy, then definitely we can start performing a biophysical profile from 24 weeks onwards itself. But here there was no risk as such, so definitely it can be ruled out. Immediate lower segment cesarean section is definitely not recommended. Why? To deliver a baby before the period of viability, that is 28 weeks. So the answer over here would be option C, 75 grams of oral glucose tolerance test. Why? As we all know, in all pregnant females, please remember, not only in high risk, rather in all pregnant females, in the second trimester of pregnancy, guys, in second trimester of pregnancy, that means after 24 weeks of gestation, there is a high risk of gestational diabetes mellitus. right? That is diabetes mellitus of pregnancy. And therefore, to rule this out, we will perform the investigation of choice, and that is a 75-gram oral glucose tolerance test, also termed as OGTT, right? So if I talk about gestational diabetes mellitus, is it lagging? Please let me know if it is lagging from my side. If I talk about gestational diabetes mellitus, guys, usually, okay, great then. Gestational diabetes mellitus is when there would be hyperglycemia or diabetes mellitus in the pregnant female after 24 weeks of gestation. If it is before 24 weeks of gestation, then it is actually called as a pre-existing or a overt diabetes mellitus. It would be called as pre-existing or overt diabetes mellitus if it occurs before 24 weeks. If it is after 24 weeks, definitely it would be a gestational diabetes mellitus of pregnancy, right? So which is the hormone responsible? Please answer. Please answer in the chat box. Whatever you know from the below given questions, please keep on answering in the chat box. You should be active throughout the session. Which is the hormone responsible for gestational diabetes mellitus? Estrogen, progesterone would be responsible, but they are not the main cause. The most important hormone. Very good, Sarah. Very good. It is HPL. That is your human placental lactogen. So human placental lactogen, it actually has a insulinase action. That means it will break down insulin. So if it breaks down insulin, what will happen? There would be deficiency of insulin in the mother, and that can cause diabetes mellitus, right? So please remember, human placental lactogen is the most important hormone responsible for gestational diabetes mellitus. If I talk about gross congenital anomalies, GCR, gross congenital anomalies, what is the risk of gross congenital anomalies? Somatostatin is not responsible. Mainly it is HPL followed by estrogen, progesterone, and Hcg. Gross congenital anomaly. Please remember, large baby or macrosomia would definitely be seen in a diabetic mother. Okay, macrosomia or a large baby, when we say the baby's weight is more than 4 kg, it is definitely a complication seen in the diabetic mother, but it is not a gross congenital anomaly. Okay, it is not a gross congenital anomaly. It is only due to the increased levels of glucose. Okay, excess of nutrition that the baby is getting. Therefore, there is a large size of the baby or macrosomia is seen. It is not a gross congenital anomaly. Is there any risk of gross congenital anomaly in gestational diabetes mellitus? Very good, anonymous. There would be no risk of gross congenital anomaly in a patient of gestational diabetes mellitus, because please remember, the period of organogenesis is usually the first trimester, around 6 to 10 weeks of gestation. Here in gestational diabetes mellitus, it is usually after 24 weeks when there would be impaired glucose tolerance in the patient. Therefore, it would have no effect on the organogenesis as such, and therefore there would be no risk of the gross congenital anomalies in the fetus if a patient is having gestational diabetes mellitus. There would be a risk of gross congenital anomalies in the fetus in cases of pre-existing or overt diabetes mellitus in the mother, when the patient is having high blood glucose levels even in the first trimester of pregnancy, and that will definitely interfere with the organogenesis of the fetus. Okay, so this is important. Please remember, what is the best test for diagnosis? As we discussed already, that is OGTT. 75 grams of glucose is given, and fasting 1 hour postprandial and 2 hour postprandial levels are usually taken into account, and then we diagnose diabetes mellitus. It is your oral glucose tolerance test. It is screening as well as a diagnostic test for gestational diabetes. Whereas for assessment of risk of gross congenital anomaly, what is the test we perform? It is usually HbA1c. So we try to perform the level of HbA1c, which tells us about the glucose control of last 3 months. Okay, and that will tell if the patient is having or the fetus is having a risk of GCA or not. Drug of choice is definitely insulin. Why insulin? Please remember, it does not cross the placenta. Okay, insulin is a drug which does not cross the placenta, and therefore it is preferred in cases of pregnancy. Whereas the oral hypoglycemic agents like metformin or others, they can cross the placenta and again can lead to some fetal defects, and therefore that to be avoided during pregnancy. Okay, so this is easy. I hope all of you were able to give the answer. Question number 5. Yeah, I'll come to that resistance part. Definitely due to human placental lactogen, there would be insulin resistance in the patient. Okay, apart from insulinase action, there is also increase in the insulin resistance, which also leads to diabetes. So this is very easy. You need to find the obstetric score of the correct obstetric score of the patient. So let's understand this, how it is done. A 27-year-old multi-para woman, okay, came to the OPD with a single pregnancy at 10 weeks of gestation. She has two twin sons already, who are 7-year-old, and a 3-year-old daughter born at term, and also had a first trimester abortion, and also delivered a dead child at 32 weeks of gestation. Which among the following is the correct obstetric score? So let's do it. Okay, easy. First of all, if I talk about gravida, gravida means how many times the patient has been pregnant, or how many times the patient has conceived, right? That is termed as gravida. If she has conceived only once, then it is called as primi gravida. If she is conceiving for the first time, it is primi gravida. If she has conceived already in the past, then it is called as multi-gravida or multi-gravida, right? If I talk about parity, what do we mean by parity? Most of you confuse over here. So please remember, when the pregnancy goes beyond 20 weeks of gestation, it is termed as parity. Okay, any pregnancy less than 20 weeks of gestation, it would not be termed as parity. Okay, parity is only said when the pregnancy goes beyond 20 weeks of gestation, right? If there is only one pregnancy which went beyond 20 weeks, it would be called as primipara. Whereas if there are pregnancies more than one which have went beyond 20 weeks, the patient would be called as multipara. Just in our case, where she is called as a multipara, right? So let's come to the obstetric score. I hope this was easy now. Okay, so G for gravida, P for parity, L goes for live births, right? How many living children does she have right now? A goes for abortion. What do we mean by abortion? This is important, guys. Okay, I have said first trimester abortion, but a dead child at 32 weeks. Why I did not call it abortion at 32 weeks? So please remember, this is important to make a difference between a stillbirth and abortion, right? So please remember, if the birth weight of the fetus is less than 500 grams, it is considered as abortion. And if the birth weight is more than equal to 500 grams, it is considered as a stillbirth. First thing. Secondly, if the fetal loss is less than 20 weeks of gestation, it is considered as abortion. If it is more than 20 weeks of gestation, it is considered as stillbirth. But in India, we have a different norm. This 20 weeks is usually according to the US norms. As we know, in US, the period of viability. What do we mean by period of viability? That means after which the neonate or the fetus can be kept alive with all the health facilities that we have. That is known as period of viability. In India, the period of viability, please remember, it is 28 weeks. So here the definition changes. In India, abortion is anything less than 28 weeks and stillbirth is anything more than 28 weeks. Okay? Because we have the capability to make live a fetus after only 28 weeks. Okay, before that we cannot actually we cannot help the fetus to live. Okay, because we do not have those developed facilities as such. So let's come to the obstetric score now. So definitely, how many times she was pregnant? Let's calculate that. Single pregnancy at 10 weeks, G1. Two twin sons, though there are two twins, she was pregnant only once, therefore it would be counted as one. In twin pregnancy would be counted as one only. Please remember this. So this would be 2. Okay, so this would be 2, G2. A 3-year-old daughter, that means G3. First trimester abortion, again she was pregnant, so G4. And a dead child delivered at 32 weeks, that means G5. So where we have G4, that can be easily ruled out, so option B is ruled out, right? Then if I talk about parity now, it is easy now. So please remember, when the pregnancy went beyond 20 weeks of gestation. In the first one, she says current pregnancy is at 10 weeks of gestation. So that means it cannot be counted as parity. Second, she has two twin sons delivered already. So that would be your first parity. Next, 3-year-old daughter born at term, definitely that would be your second parity, right? First trimester abortion cannot be counted as a parity again. And a dead child at 32 weeks of gestation. So this pregnancy went beyond 20 weeks. So this would be your third parity. Okay, so this would be your third parity. So P3, definitely P4 can be ruled out. P5 can be ruled out. So definitely you have the answer. That is option A is the right answer. G5, P3, L3. As we know, she has 3 living children, 2 twin sons and 1 3-year-old daughter. So total 3 children are there. 1 abortion at 10, almost at 10 weeks, and the 1 stillbirth at 32 weeks, right? So I hope this was easy now. Moving further, guys, talking about question number 6. So this was easy. Let me know your answer. A woman whose obstetric score is G2, P1, L1. That means 2 times she was pregnant. one times went beyond 20 weeks, and one living child she has. Had a last menstrual period, LMP, of 9 January 2022. Calculate the EDD, that is expected date of delivery, according to the Nagar's rule or the Nagar's formula. So I hope all of you are aware of this Nagar's formula. It is asked in multiple examinations, guys, so it is important. And also in clinical practice, you need to calculate the expected date of delivery. So how do you calculate? You actually take into account the last menstrual period. And what do we mean by last menstrual period? It is the first day of the last menstrual period. Please remember, it is the first day of your last menstrual period when the menses began, right? Then we will add 7 days to it, right? We will add 7 days to it, and then we will subtract 3 months from it. We will subtract 3 months from it. Okay. If the pregnancy usually occurs from Jan till March, then you do not need to change a year, or you do not need to add an year. Okay. But whereas if the pregnancy is after March, then definitely the LMP was after March, then definitely you need to add one more year. That means if it was 2022 March, then you need to add 2023 now, right? 1 year should be added. So I hope all of you have got the answer. The LMP was 9 Jan. So we need to add 7 days. That means it would be 16th Jan. And if we subtract 3 months from it, Jan to December, December to November, and November to October. So the expected date of delivery would be option B, that is October 16, right? So it is usually when we consider the length of the menstrual cycle to be 28 days. Sorry. The length of a menstrual cycle on an average is 28 days. So when the length of the menstrual cycle is 28 days, then it would be October 16. But if they say that the length of the menstrual cycle was 35 days, okay, the patient was having oligomenorrhea and the length of the menstrual cycle was 35 days. So you need to add 7 more days to it, and then it would become around October 23, right? Then it would become October 23. And if the patient was having polymenorrhea and it was like the patient was having a menstrual cycle of only 25 days, then you will subtract 3 days from the expected date of delivery, and it would be somewhere around October 13, right? So it differs likewise. Please remember, if they give you the then subtract accordingly. So please remember, if they give you the length of the menstrual cycle, accordingly you need to make the changes in it. If I talk about ANC visit, which is the most important question from PSM and OPS as well, antenatal care visits. That means when a pregnant female will go to the hospital, okay, for the routine checkup. When a pregnant female goes to the hospital, this is called as ANC visits. Okay, PNC visits are after delivery, when a healthcare worker goes to a pregnant female's house. Okay, that is different. So what are the recommended ANC visits according to WHO? The recommended number of ANC visits according to WHO. Please tell me the recommended number of ANC visits according to WHO. Recommended, I am asking, guys, it is usually 13 to 14 visits, right? 13 to 14. So the patients who are living in urban areas for whom the healthcare facility is easily accessible, so definitely they can like have 13 to 14 visits, out of which there would be in the first 7 months each like 1 visit every month. Okay, so please remember, in the first 7 months 1 visit every month, so that makes it a total of 7 visits. Then in 8th month usually 2 visits. Okay, in 8th month 2 visits, and in 9th month onwards, that means after 36 weeks of gestation, 1 visit weekly. Okay, 1 visit weekly. That makes it a total of 4 to 5 visits. Until delivery, the patient will visit the hospital. So some patients would have 4 visits, some patients would have 5 visits. So in total, it is 13 to 14 visits. But if they ask you the minimum WHO antenatal care visits, this question was asked. Now the answer from 4, it has changed to 8. Please remember. Okay, the better answer to be marked is that is 8 according to WHO wise. In India, we will still follow 4, but according to WHO, it is 8. Please remember, the minimum number of antenatal visits, they have increased it to 8 now, not 4 anymore. Very good. Question number 7. Okay? A Rh negative patient pregnant, she would require anti-D prophylaxis in all the below given events, except for in which condition she would not require an anti-D serum or an anti-D prophylaxis. So if I would you like me to explain about Rh negative pregnancy, how the second fetus dies? If please let me know, then I can go further with it. It would be short, like 1 or 2 minutes. Okay. So please remember, guys, usually what happens if we have a rhesus negative female, that means a RS negative female, maybe her blood group would be something like O negative, okay, and she is pregnant for the first time. That means in first pregnancy, she has a baby who is RH positive, okay. So the first time she's having a baby who is RH positive, right? So now what can happen? The mother is not used to this D antigens. As we know, RH positive is said when there are D antigen on the RBCs, right? The mother is not used to these D antigens in a circulation. So if in case, if there is any feto-maternal hemorrhage, that means mixture of the fetal and maternal blood, what can happen? The mother's body could not recognize these D antigens, and it would recognize these D antigens as something foreign, okay, and therefore it will start producing antibodies against it, okay, and therefore it starts producing antibodies against it. But usually the feto-maternal hemorrhage commonly occurs during the period of delivery, okay. So usually the first fetus is saved, because if after delivery these antibodies are formed, definitely there would be no risk to the fetus because the fetus has already been delivered. But what happens if the patient has not been given anti-D serum in the first pregnancy? What happens in the second pregnancy when she's again having a baby who is RH positive, again having a baby who is RH positive, this time again her blood would be exposed to something like D antigen, okay, and now she knows this is a foreign substance. Her body knows that this is a foreign substance and we have preformed antibodies against it. So these antibodies will try to attack these D antigen and it will kill the fetus by something known as Hydrops fetalis. It will kill the fetus by something known as Hydrops fetalis or erythroblastosis fetalis, right? There would be accumulation of like fluids in the serous cavities like pericardial, peritoneal, and like your pleural cavities, right? Edema, ascites, everything would be there in this patient. So the second baby would usually die. The first baby would be safe in these cases, okay. But if anti-D serum is given in the first pregnancy, in second pregnancy there would not be any risk in this patient, right? So let's see. Usually, please remember, when do we require anti-D prophylaxis or anti-D serum? Whenever there is a risk of feto-maternal hemorrhage or whenever there is risk of mixture of fetal and maternal blood, right? So where there is a risk of fetal and maternal blood. So first of all, option C is miscarriage. Miscarriage, or in cases of abortion, yes, there would be bleeding from the fetus as well as from the mother, and therefore there would be a high risk of feto-maternal hemorrhage. And in cases of miscarriage or abortion, usually during first trimester, we will require anti-D prophylaxis to be given, but the dose is not standard. It is rather 50 micrograms. Okay, the normal standard dose of anti-D serum is 300 micrograms after delivery. Okay, 300 micrograms. But here it would be only 50 micrograms. Option B says chorionic villus sampling or one more procedure which is known as amniocentesis. Both of these procedures are used to diagnose aneuploidies in a fetus, right? In chorionic villus sampling or amniocentesis, these both are invasive procedures where we will take samples either from the chorionic villi or from the amniotic fluid, right? And therefore there would be a risk of again feto-maternal hemorrhage. So definitely we will require anti-D serum here as well. Option C says ectopic pregnancy. Again, whenever there is a ruptured ectopic pregnancy, there would be risk of hemorrhage. So again, anti-D serum would be required over here. In cases of postpartum hemorrhage, definitely we will not require anti-D serum. Why? Because please remember, if there is a postpartum hemorrhage, that means the fetus has already been delivered, and after delivery, usually after the third stage of labor, there would be excessive hemorrhage. So in this case, the baby has already been delivered. Therefore, it is only the maternal blood. Okay, there is no risk of feto-maternal hemorrhage as such. So the exception over here would be PPH. Usually the most common cause of Hydrops fetalis, if they ask you guys, please remember, it is not RH incompatibility or it is not an immune cause. Rather, it is a non-immune cause. Okay, and the most common cause are usually cardiac defects. Okay, the most common cause are cardiac defects, like something like congenital heart block. It can be also caused by an infection known as parvovirus B19. Okay, it causes complete heart block. Therefore, there would also be a risk of Hydrops fetalis in cases of parvovirus B19 infection during pregnancy. Okay, please remember that. So in cases of RH negative pregnancy, we perform an investigation known as ICT, that is an indirect Coombs test. Why is this ICT performed? To check for the levels of antibodies in the mother. Okay, so we try to check the levels of antibody titer batata hai hame ye, the indirect Coombs test, right? And this should be performed at what week? So please remember, it should be it should be performed from the first week of from the first visit of the pregnant female itself. Okay, it should be started from the first visit of the pregnant female itself. till 1:16 dilution, if it is positive, it is absolutely safe. Okay, till 1:16 dilution, if it is positive, it is absolutely safe. Beyond that, if it is 1:32 dilution positive, then definitely the fetus has a risk. Okay, then definitely the fetus has risk. Anti-D serum, as we know, the normal standard dose is 300 mcg, and it is usually known to neutralize 30 ml of fetal blood. It is known to neutralize 30 ml of fetal blood. If fetal-maternal hemorrhage is more than 30 ml, then 300 micrograms of SCG would not be enough, and more amount of anti-D serum should be given to this patient. Okay, and therefore we will perform a quantitative test. Okay, we will perform a quantitative test where we will actually get to know how much amount of fetal-maternal hemorrhage has occurred. So this quantitative test is also known as the acid elution technique, where we will pour acid on the blood. Okay, and the maternal RBCs will lose its color. Okay, the maternal RBCs will lose its color, whereas the fetal RBCs, they will not lose its color and they will remain red in color. Okay, they will resist the acid and they will still remain red in color. So you can count the number of the fetal RBCs, and with the formula you can actually come to a conclusion that how much amount of fetal-maternal hemorrhage has occurred in the patient, and accordingly you can give the anti-D serum which is required in this patient. And this quantitative test is known as, anybody? No, please remember. Yes, very good. It is the Kleihauer-Betke test. First answer should be the quantitative test that we have. It is known as the Kleihauer-Betke test. Whereas the qualitative test, they are alkali denaturation tests like the APT test or the Singer's test. So please remember, quantitative Kleihauer-Betke, qualitative Singer's or APT test. Okay, no issues with this. And anti-D serum as prophylaxis should be started from, so please remember, it should be started from 28 weeks of pregnancy, and it is given every 6 weeks. That means next it would be given at 34 weeks, and then it would be given at around delivery. Okay? Very good, anonymous. Question number 8 now. It says a 25-year-old primigravida, that means pregnant for the first time, presents with lower abdominal pain and vaginal spotting. On palpation, tenderness is noted. UPT, that is urine pregnancy test, was performed and that was positive. Beta SCG levels were 1500 international units. Both of these are suggestive. That means the patient is definitely pregnant, right? She is having abdominal pain, vaginal spotting. UPT and beta SCG both are positive. Ultrasound performed shows no double decidual sac sign. That means it is not an intrauterine pregnancy. I hope all of you are quite aware. On an ultrasound in the uterus, if we can see the double decidual sac sign, it is usually suggestive of an intrauterine pregnancy, right? So this two sacs, the inside one is made by the decidua capsularis, the outer one by the decidua parietalis. So this is known as the double decidual sac sign, which is suggestive of intrauterine pregnancy. But in this patient, the double decidual sac sign within the uterus was not seen, but an adnexal mass was noted. So this is important, adnexal mass. That means the mass was not in the uterus, but somewhere else, like in the fallopian tube or in the ovaries or maybe in the round ligament, somewhere else, right? What will be the most appropriate next step in the management of this patient? So can anybody tell me the provisional diagnosis in this condition? Very good. Yes, it is ectopic pregnancy, right? So please remember, whenever a patient presents to you with amenorrhea, lower abdominal pain and bleeding, the first thing that you will suspect is pregnancy. But if on pregnancy, the ultrasound shows no double decidual sac sign, the second thing that you will suspect is definitely ectopic pregnancy. So here the diagnosis is ectopic pregnancy. What should be done in this case, guys? So let's study about ectopic pregnancy, the important things. Okay, I'll not bore you again. So ectopic pregnancy, if the implantation of the blastocysts occurs anywhere apart from the uterus, it is called as an ectopic pregnancy. What is the most common site of ectopic pregnancy? Keep on answering whatever questions you can see, keep on answering in the chat box. Very good. So please remember, the most common site of ectopic pregnancy is actually your fallopian tube, right? It is your fallopian tube followed by ovaries, right? And in fallopian tube, there are four parts. The infundibulum is there, then your isthmus, ampulla, and the interstitium. Out of all of that, it is the ampulla which is the most common site within the fallopian tube, right? Because it is the widest portion of the fallopian tube. And second reason, fertilization usually occurs inside the ampulla. So if fertilization occurs, zygote formation occurs, but after that, if the zygote is not pushed towards the ovary with the help of peristalsis, it will remain in the ampulla, and that would lead to a ectopic pregnancy, right? Most common cause for ectopic pregnancy, anybody, guys? Most common cause for ectopic pregnancy. Please remember, guys, IUCD, intrauterine contraceptive device, any type of contraceptive device will decrease the rate of pregnancy. Definitely, it is a contraceptive. That means it is used for avoiding pregnancy. So it will decrease the risk of all pregnancies, including ectopic. But in case if there is a failure of IUCD or failure of contraception, then among the normal risk of ectopic and the risk with failure of contraception, it would be more with failure of contraception. Normally it is 1%. In failure of IUCD, it would be 5%. Okay, but all pregnancies would be decreased with the help of IUCD. Okay. So definitely it is PID. Please remember that is your pelvic inflammatory diseases, right? And pelvic inflammatory disease including like involving the fallopian tube is known as salpingitis, right? Inflammation of the fallopian tube. And that is the most common cause why there is a peristalsis of the fallopian tube and there would be ectopic pregnancy over here. What is the criteria? Sorry. There are multiple criteria for different types of ectopic pregnancy, guys. But for the ovarian ectopic, which is the second most common type, we have a criteria known as the Otto-Spiegelberg criteria. Very good. It is the Otto-Spiegelberg criteria. Whereas for abdominal ectopic, you need to remember, for abdominal ectopic, it is the Study-Ford criteria. Not Spender's, please remember, it is the Study-Ford criteria. Okay, it is the Study-Ford criteria. So important to remember these two. O for ovarian, O for Otto-Spiegelberg criteria, A for abdominal for Study-Ford criteria. What is the most common symptom? Very good. Pain abdomen is the most common or the most consistent symptom in cases of ectopic pregnancy. But if they ask you which is the most common or the most consistent sign, then your answer should be, if you perform a pervaginal examination and you move the cervix, then there would be pain. This is called as cervical motion tenderness. This is called as cervical motion tenderness, which is also one of the important signs of pelvic inflammatory disease, right? So most common sign or most consistent sign would be cervical motion tenderness. Okay. So here you can see laparoscopy, right? On laparoscopy, you can see the uterus. These are the fallopian tubes on both the sides. And in this fallopian tube, you can see an ectopic mass, which is there. This is the ectopic pregnancy that you can see. Okay. So let's talk about our question first. So we have studied about ectopic pregnancy. Yeah, I'll come to that for ruptured ectopic management. Before that, we will discuss about unruptured ectopic. Here, the patient is not having excessive bleeding per vagina. There is only vaginal spotting. Okay, a minute bleeding which is seen. Right. So definitely we cannot suspect a ruptured ectopic. Usually in ruptured ectopic, there would be excessive bleeding and that will lead to hemoperitoneum and the patient will go in shock, or there would be hemodynamic instability, which is not seen in our patient. So definitely we can say our patient is having actually a unruptured ectopic pregnancy. Okay, first thing. Okay. So what should be done in this case? So it is easy. For unruptured ectopic pregnancy, we can either perform a medical management or a surgical management. Three important criteria. Question has been asked in December. This is important. Three important criteria. First, you need to check the size of the mass or the size of the fetus. If the size of the mass, okay, if the size of mass is less than 4 centimeter, you will perform medical management. If the size of mass is more than 4 centimeter, you will perform surgical management. Okay, next, it is your beta HCG levels. If beta HCG levels, they are less than 5,000 international unit, you will perform medical management. If they are more than 5,000 international unit, you will perform surgical management. And the third and the most important thing, guys, sorry, on an ultrasound, if you are able to see the cardiac activity, if cardiac activity is present, then you will perform a surgical management. If it is absent, then a medical management. Okay, what is done for medical management? Please remember, for medical management, we will give a single dose methotrexate in this patient, right? Whereas for surgical management, the surgery of choice or the surgical treatment of choice for ectopic, unruptured ectopic pregnancy is actually a laparoscopic linear salpingostomy. What do we mean by linear salpingostomy? We will make a linear incision. Okay, we will make a linear incision on the fallopian. Okay, we will make a linear incision on the fallopian tube, open it and remove the mass. Okay, and leave the cut edges as it is. We will not suture it back again. If we suture it back again, then it would lead to adhesions, and this procedure would be called as salpingotomy. Here we will leave the cut ends as it is. This is known as salpingostomy, which is the surgery of choice, okay, in unruptured pregnancy. But let's see here. Please remember, they have not given about the size of mass. they have not given about the cardiac activity. Only the criteria they have given is the beta HCG levels. Here the beta HCG levels are 1500 international units, less than 5000. So therefore the treatment of choice in this condition should be option D, medical management. Single dose methotrexate injection is given to the patient. Okay, so please remember, yes, single dose methotrexate injection is usually given. Yes, 50 mg it is given. Very good, guys. Continue pregnancy, definitely it is ectopic. We would not take a risk because there is a high risk of tubal abortion or high risk of tubal rupture in this case. Therefore, we would not continue the pregnancy at any cost. Repeat ultrasound is not required anyways. Okay, so if in case khuda na khasta, if this pregnancy ruptures, okay, this ectopic pregnancy ruptures, then how to manage it? First of all, the most important thing here, the patient would go in shock. That means there would be hemodynamic instability in the patient. Apart from that, you can see the peritoneal discoloration, right? So there would be peritoneal bleeding or hemoperitoneum, which will lead to two signs. First, periumbilical discoloration. This is known as the Cullen sign. Okay, this is known as the Cullen sign. Whereas brownish discoloration in the flanks, it is known as the Gray Turner sign. Okay, these are the two signs seen in cases of hemoperitoneum. These are the signs seen in cases of hemoperitoneum. Okay, so here, if you diagnose it as a ruptured ectopic pregnancy, the patient would come to emergency with excessive pain, excessive bleeding per vaginum, the features of hemoperitoneum, shock, all of these features. Then a ruptured ectopic should be managed, okay, by total salpingectomy. That means you will not save the tube. You will not save the tube. You will rather remove the tube. Okay, the affected tube would be removed. Why? Even it is a nulliparous woman or a multiparous woman, you will remove the tube because it has already been ruptured, and there would be a higher risk of other conditions like pelvic inflammatory disease, or there can be high risk of again ectopic at the same site. Therefore, you will not repair the tube. Okay, you will directly remove it. That is known as total salpingectomy. Okay, and it is performed by laparoscopy or laparotomy. Anybody? So the patient is in shock. If she is not in shock, definitely we can prefer laparoscopic procedure. But here she is in shock, therefore definitely we'll directly cut the abdomen, and that would be known as laparotomy. So laparotomic total salpingectomy would be performed. Would we remove the ovaries in this case? Salpingo-oophorectomy would be performed. Would we perform a salpingo-oophorectomy? Ectopic pregnancy in a 25-year-old woman. Very good. Anonymous. We will not perform a salpingo-oophorectomy. Okay, abstain from marking it as an answer. Oophorectomy or removal of ovaries is not done in cases of ectopic pregnancy. Please remember this. Okay. I hope I have answered all your queries regarding ectopic. This is the most important topic from OBS. So please remember this. Question number 9, guys. It says a patient presents to the antenatal clinic at 28 weeks of gestation. A modified biophysical profile was performed. AFI, that is your amniotic fluid index, was calculated to be 4 centimeters. All below given following conditions are implicated as a cause in this condition except. So first of all, let's like all of us are quite aware of what is the modified BPP or modified biophysical profile. Previously, we used to use the Manning score of biophysical profile, where there were 5 parameters and total score of 10 was there. But nowadays, we only use the most important 2 parameters in this case in modified BPP. And first one is a non-stress test, right? Non-stress test is said to be reactive. We usually measure the fetal heart rate. Okay, so non-stress test is said to be reactive when there are more than 2 accelerations of more than 15 beats for at least a period of more than 15 seconds. Then it is considered to be a reactive non-stress test. Along with that, the second and the most important component is AFI. That is the amniotic fluid index. You will measure the amount of the amniotic fluid. Okay, so that is amniotic fluid index, and this is usually like measured with the help of ultrasound, right? How do we measure it? So please remember, we will divide the uterus in 4 quadrants, and in each quadrant we will take a single largest pocket, and then we will add those pockets total. Okay, we will make a total of these pockets. That would be your normal amniotic fluid index. What is the normal AFI? So the normal AFI is around 5 to 24 centimeters. Okay, the normal AFI is around 5 to 24 centimeters on an average. They say 20 to 15 centimeters, right? Anything, okay, anything less than 5 centimeters, anything less than equal to 5 centimeters is considered to be oligohydramnios or oligoamnios, decreased amniotic fluid. And anything more than 24 centimeter or more than equal to 25 centimeter would be considered as polyhydramnios, increased level of amniotic fluid, right? Please remember, if I talk about amount of amniotic fluid, normal amount of amniotic fluid is around 1000 ml, right? It is around 1000 ml and it reaches peak. So this was a question, recall question, please answer it. Maximum amount of amniotic fluid during pregnancy is seen at which week of gestation? So if amniotic fluid value is less than 500 ml, it would be termed as oligohydramnios. If amount is more than 2.5 liters, it is termed as polyhydramnios. Some books say more than 2 liters as well. So anybody, maximum amount of amniotic fluid is seen at which week of gestation? So please remember, there was option 32, 33, 32, 34, 36. So please remember, it is seen around 32 to 34 weeks of gestation. Maximum amount of amniotic fluid is seen around 32 to 34 weeks of gestation. After 34 weeks, usually the amount of amniotic fluid decreases to around 800 or 700 ml till term. Please remember. Okay, so maximum value is around 32 to 34 weeks. Last time 34 was not an option. Therefore, the best answer was 32 weeks in December session. Okay. Then if I talk about the causes of like this condition, what is seen? Antenatal clinic by IA patient for fetal surveillance, definitely we would have performed a modified BPP in this patient and AFI was calculated to be 4 centimeter. It is less than 5 centimeter. Definitely it is oligohydramnios. The provisional diagnosis in this condition is oligohydramnios. So all of these conditions will lead to oligohydramnios except for which condition causes polyhydramnios. Let's see. Option A says renal agenesis. Rather, this is the most common cause of severe oligohydramnios. Why? Because as we know, amniotic fluid is mainly, like usually during the initial days of pregnancy, it is made from the maternal plasma. Then in second trimester, it is made from the fetal skin. And usually around third trimester, when it is maximum, the main component of amniotic fluid is usually your fetal urine, right? It is mainly the fetal urine. But if in case the patient's kidneys are not developed, if there is renal agenesis, fetal urine would not be formed and therefore there would be less amount of amniotic fluid, and therefore in cases of renal agenesis, the patient would lead to, or the patient would have oligohydramnios. Rather, it is the most common cause of severe oligohydramnios. Pregnancy induced hypertension, definitely it is also one of the causes of oligohydramnios. Okay, please remember. ACE inhibitors, definitely drugs like two important drugs you need to remember. First, ACE inhibitors, and second, indomethacin. Okay, second, indomethacin. These two drugs are known to cause oligohydramnios in a pregnant patient, and therefore as indomethacin decreases the level of amniotic fluid, it is used as management in polyhydramnios. Okay, it is used as a drug of choice in polyhydramnios, but indomethacin should only and only be given up to 32 weeks of pregnancy. If it is given after 32 weeks of pregnancy, it would lead to, please answer in the chat box, if indomethacin, very good, it would lead to premature closure of the ductus arteriosus. Okay, it will lead to premature closure of ductus arteriosus. Therefore, less than 32 weeks for poly, you can definitely give indomethacin to the patient. Okay. So gestational diabetes mellitus, please remember, it will rather lead to polyhydramnios and not to oligohydramnios. So that was an exception over here. Gestational diabetes mellitus or maybe over diabetes mellitus, what happens? There is increased blood sugar level. Therefore, there would be increased sugar levels in the amniotic fluid also. Okay, and that will imbibe water, okay, into the amniotic membrane, and that will increase the amniotic fluid levels. Okay, please remember this. Along with that, the second most important cause, the fetus would also have hyperglycemia. If mother is having hyperglycemia, fetus also has hyperglycemia, and therefore the classical symptom of diabetes, polyuria, and therefore due to polyuria, there would be polyhydramnios in a patient of gestational diabetes mellitus. Apart from that, it would also be seen in congenital anomalies, and one of the important one that you need to remember, it is esophageal or duodenal atresia. If there is a esophageal or duodenal atresia, there would not be any like swallowing of this amniotic fluid. If the amniotic fluid is not being swallowed, therefore there would be constant increase in amniotic fluid that will lead to polyhydramnios. This is important. Congenital atresias like esophagus or duodenal atresias can be diagnosed with the help of polyhydramnios during pregnancy. At least we can suspect it. Okay, please remember this. Very good. Yeah, in cleft palate, cleft lip also there is a risk of polyhydramnios. And ACE inhibitors are definitely contraindicated during pregnancy because along with oligohydramnios, they are also teratogenic to the fetus. Okay? Question number 10, guys. It says an intern was asked to estimate the fetal age or the gestational age, sometimes they call it, right, by examining the fundal height of a patient who was pregnant. She says the fundus is almost at the level of Zipf's sternum. What is the estimated fetal age? So if you are an intern posted in OBG, one of the important things that comes to you is only assessing the fundal height of the patient and telling what is the estimated fetal age. Okay? And second is listening to the fetal heart sounds with fetal Doppler. That are the only two things you do in OBG. Okay? So please remember, these are the important markers that you need to remember. At least 2 or 3 of them I'll mark that you need to remember at any cost. Okay. So first, please remember, if the fundus of the uterus is at the level of the pubic symphysis, if it is at the level of pubic symphysis, the pregnancy would be around 12 to 14 weeks. Okay. If the fundal height is around at the level of the umbilicus, then the fetal age or the gestational age would be around 20 to 22 weeks. At the level of umbilicus, it is around 20 to 22 weeks. And if the fundal height is around or at the level of the Zipf's sternum, then okay, if it is at the level of Zipf's sternum, then usually the gestational age or the fetal age would be 36 weeks. And as I told you, after 36 weeks, usually the height of the uterus decreases because the fetal head would go into the pelvis, right? And around 40 weeks, okay, it would be 2/3 from the distance of the umbilicus and Zipf's sternum. Okay, it would be around a 2/3 distance from the Zipf's sternum to the umbilicus. Okay? So at 32 weeks and 40 weeks, it is almost at the same level below the Zipf's sternum. Okay? At least this is to be remembered. And here she says almost it is at the level of Zipf's sternum. So the answer should be option B, 36 weeks. Right? The gestational or fetal age in this condition is 36 weeks. So at least these 3 landmarks of these 4 landmarks you should remember. Moving further, talking about these manures, just remember what is the name of this manure. It is usually performed during pregnancy. I'll explain. Till that, please tell me the name. This was asked, what is the manure? So this usually are 4 manures. The first manure that we have here, we are trying to palpate the sides of the uterus. And what are we trying to palpate actually? We are trying to actually palpate the fundus over here. Okay, first in this, we are trying to actually palpate the fundus. We try to check the shape, the mobility, or the consistency of the fundus in first manure. Second manure, we try to palpate the sides of the uterus. Over here, we try to check for the back. Okay, which side is the back of the fetus facing? Third manure is this one, which is also called as, this was asked. This manure is also called as, so this manure is also called as Pollux grip, or Pollux grip is which manure of Leopold. So the manure's name is actually the Leopold's manure. Okay, it is the Leopold's manure. And the third Leopold manure is actually known as the Pollux grip, where we try to palpate the presenting part. Okay, in the lower segment of the uterus, which is the presenting part, we try to palpate. Okay, it can be cephalic, it can be breech presentations as well. And the fourth manure, we usually turn our head towards the feet of the patient and again try to palpate the sides of the uterus. This time we are trying to palpate or try to look for the attitude of the fetus, where the fetus is having a flexed attitude or a deflexed or an extended attitude, that we are trying to locate. Okay, no issues with this. Moving further, question number 11. A patient at 27 weeks, a patient 27 weeks pregnant came for a routine antenatal checkup, and on a routine ultrasound, a diagnosis of placenta accreta was made. Which among the following statement is false or incorrect regarding a diagnosis? So you need to mark the incorrect or the false statement. I hope all of you are quite aware of placenta accreta, right? So normally the placenta is not at the fundus. Please remember, the placenta is usually not at the fundus. It is on the posterior wall of the uterus. Okay, but it is on the, but it is usually in the upper segment. Okay, it is usually in the upper segment. But if okay, it is lying down, like lying in the lower segment, it is called as placenta previa. Okay. Apart from that, the second thing that you need to remember, this is a normal placenta attachment. What happens? This is the placenta which I am marking. Okay, the blue one, and beneath that you can see a slight orange layer. This layer is actually a fibrinoid layer. Okay, this is a fibrinoid layer known as the Nita Bush layer. This is a fibrinoid layer known as the Nita Bush layer, and this fibrinoid or Nita Bush layers helps in separating the placenta easily. So after delivery in the third stage of labor, during delivery of placenta, it would be released easily because it is not attached to the endometrium or myometrium. It is attached to this fibrinoid Nita Bush layer. Okay, if it is attached to the endometrium or the myometrium directly, okay, then that is known as what is called as the placenta accreta syndrome. If it is attached only to the endometrium or the superficial myometrium, it is called as placenta accreta, which is the most common type. If it is invading the myometrium, it is called as placenta increta. Okay, I can like magnify it for you. So if it is only till the endometrium or the superficial myometrium, placenta accreta. If it is invading the myometrium, it is placenta increta. And if it is going till the serosa, it is called as placenta percreta. Okay, most common is placenta accreta syndrome. So what is false regarding a diagnosis? Let's see. Option A says gold standard investigation is MRI. Right. In this condition, please remember, ultrasound would be the initial investigation. Okay. But the gold standard investigation would only and only be a MRI, because MRI would tell you about the walls of the uterus. Okay. How the walls of the uterus are, or how the attachment of the placenta is. So definitely MRI is the gold standard investigation in placenta accreta. Option B says elective classical cesarean section shall be performed. So please remember, in this condition, a cesarean section is definitely indicated, because it is commonly associated with placenta previa, and therefore it is recommended to perform a cesarean section in this condition. And along with that, we also need to remove the uterus. Okay, hysterectomy is recommended in all cases of placenta accreta. Why? Because usually there would be higher chances of placenta accreta or other complications, okay, in the female after that, in the subsequent pregnancies. Therefore, it is recommended, even if she is first time pregnant, it is recommended to perform a hysterectomy in all cases. So this statement is also true. And that is why with a normal vaginal delivery, we can definitely could not perform a hysterectomy. Therefore, a cesarean section is indicated, with which we can also perform a hysterectomy. But why a classical and not a lower segment cesarean section? Because as I told you, it is commonly associated with placenta previa. If I perform a lower segment, there is a higher risk of that placenta previa bleeding. Okay, therefore we perform a normal classical cesarean section. So here option C is the odd man out or the false statement. The most important risk factor is not a previous cesarean section. Yes, it is the second most common or the second most important risk factor. The most common or the most important risk factor for a placenta accreta is actually a history or a current placenta previa. It is a history or a current placenta previa. That is the most important or the most common risk factor for placenta accreta syndrome. Okay, low-lying placenta, that it is. Okay, so I hope this was easier. Question number 12 now. A 27-year-old female comes to your clinic in her first trimester, and she has a history of first child with spina bifida. Spina bifida is a neural tube defect. I hope all of you are quite aware of it. Which among the following is a correct statement regarding neural tube defects in the fetus? So you need to mark the correct statement out of it. So let's study about neural tube defects. I hope all of you are quite aware. Like, neural tube defects are usually seen due to which vitamin deficiency? They are commonly seen due to folic acid or vitamin B9 deficiency, right? And folic acid deficiency. Okay, so folic acid deficiency is usually noted with anti-epileptic drugs like valproate. Okay, so with that, usually there is folic acid deficiency, and that increases the risk of neural tube defects in the patient. Okay, so now let's rule it one by one. Option A says amniocentesis is the diagnostic test of choice. Do you think it is the true statement? Please remember, definitely amniocentesis or chorionic villus sampling, I told you, are the better investigations, but they are used usually for aneuploidies. That is, they are used usually for diagnosing abnormal number of chromosomes in the fetus, like monosomy or trisomy in the fetus can be usually diagnosed with the help of amniocentesis in second trimester and a chorionic villus sampling in the first trimester, right? But they are rarely used for neural tube defects. Definitely we can use them, but they are not the diagnostic test of choice, because as I told you, investigation of choice or diagnostic test of choice should not be invasive. Okay, if it is possible, we can perform a non-invasive test, then definitely we should avoid the invasive ones. So we have a better non-invasive test to diagnose neural tube defect or any gross congenital anomaly, and that is a ultrasound. Which ultrasound? Anomaly scan. It is done in which trimester? Anomaly scan. It is done in which trimester, anybody? So please remember, if the ultrasound is performed in the second trimester, it is usually used for assessing any gross congenital anomalies in the fetus, right? It is used to assess any gross congenital anomalies in the fetus. It is called as a level 2 scan. Okay, so this level 2 scan definitely would help you assess. Rather, it is the investigation of choice to diagnose any gross congenital anomalies in the fetus, including neural tube defects. Okay, because it is non-invasive, right? It is performed around 18 to 22 weeks of gestation. This is important. It is performed around 18 to 22 weeks of gestation. So definitely first statement is wrong. Option B says start patient on tap folic acid. Definitely we need to give folic acid supplementation in this patient because the main etiology is folic acid deficiency. But how much it should be given? It should not be 500 mcg. 500 mcg of folic acid is the usual dose given in cases of normal pregnancy. Okay, in cases of normal pregnancy, the dose of folic acid is usually 500 mcg. In the Indian tablets that we have, iron and folic acid tablets that are given during pregnancy, 60 milligram of elemental iron and 500 mcg of folic acid is there. That is given in normal pregnancies. But here they are saying that the mother has a history of first child with spina bifida. That means there is a history of neural tube defect. Therefore, this is a high risk pregnancy. And if there is a high risk pregnancy, the dose of folic acid is usually 10 times. That is approximately 4 mg. Okay, in high risk pregnancy. Therefore, this statement is false. Option C says spina bifida on ultrasound will show Mickey Mouse sign. So please remember, Mickey Mouse sign sometimes also referred to as the frog eye sign. So this Mickey Mouse or frog eye sign is actually an indicator of anencephaly on ultrasound. It is an indicator of anencephaly and not spina bifida. Rather, in cases of spina bifida, we will see signs like a lemon sign or a banana sign. Okay, a lemon or a banana signs would be seen in spina bifida. At least remember the name. So again, this is the false statement. Option D is the right statement. I would say, though it is not completely right, it is partially right. Why? Maternal serum alpha fetoprotein levels are the most sensitive marker of anencephaly. Yes, definitely they are one of the most one of the sensitive markers of anencephaly. If we need to diagnose anencephaly, the best biochemical test that we have is actually acetylcholinesterase levels. They are acetyl, very good. They are acetylcholinesterase levels in the amniotic fluid levels. If these acetylcholinesterase levels in the amniotic fluid are elevated, then we can suspect anencephaly. Okay, but the second best is definitely maternal serum alpha fetoprotein. As all other statements are wrong, definitely I will prefer this. But overall best is acetylcholinesterase. Second best is maternal serum alpha fetoprotein levels, and these would usually be elevated. Please remember, maternal serum alpha fetoprotein levels are elevated in cases of neural tube defects. This is important. Whereas maternal serum alpha fetoprotein levels are decreased in cases of chromosomal abnormalities like trisomy, that is your Down syndrome. Okay, in cases of chromosomal abnormalities, the AFP levels would be decreased. This is important. Please remember. Okay, the earliest to be diagnosed, this was a question, so I am asking the earliest diagnosed congenital anomaly in a fetus, and at what weeks it can be diagnosed with the help of an ultrasound. So in first trimester also, we can definitely pick up some gross congenital anomalies. Okay, but usually the second trimester scan, that is the level 2 scan, is also called as the anomaly scan, because we can be very sure whether the fetus is having any gross congenital anomaly or not. Very good. So the earliest to be picked up gross congenital anomaly is anencephaly, and it is picked up as early as 10 weeks. It is picked up as early as 10 weeks, max, but best it is picked up at 14 weeks. Best it is picked up at 14 weeks. Okay, so please remember. Question number 13, guys. A 32-year-old pregnant female at 34 weeks presented to the antenatal clinic with complaints of headache, nausea, fatigue, right abdominal discomfort. Lab investigations revealed anemia, thrombocytopenia, LFT level shows that there is elevated ALT, that is your SGPT enzyme, and LDH, that is lactate dehydrogenase enzyme. Definitive management. What is the provisional diagnosis first? So I hope this is very easy for all of you. There are symptoms like headache, nausea, vomiting, fatigue, right abdominal discomfort. These are usually the symptoms seen in cases of preeclampsia. Right? These are the symptoms in cases of preeclampsia when there would be end organ damage in the patient. Right? So here you can see there is anemia. That means this anemia would be due to hemolysis. Then there are elevated levels of liver enzymes, that is ALT and LDH are elevated. So elevated liver enzymes. And there is thrombocytopenia, that means low platelet count. So this is actually the diagnosis of a HELLP syndrome. I hope all of you are quite aware. HELLP syndrome is one of the most important complications of eclampsia or preeclampsia, right? And what is to be done in that case? What is the definitive management in that case? So let's rule it out one by one. Option A says start corticosteroids and wait till term. Definitely, if the patient is at 34 weeks, we would not require corticosteroids in the patient because the lungs have already been matured. If the pregnancy was less than 34 weeks, definitely we would have given corticosteroids in the patient. First thing. Second, We could not wait till term because it is a severe, like it is a complication of severe eclampsia. The patient can anytime go into eclampsia, or that can complicate even further. So definitely this is not a right choice. Option B says immediate termination of pregnancy. Right, this should be your answer. Definitive management in cases of eclampsia or in cases of HELLP syndrome is always and always immediate termination of pregnancy. And as already she she is at like more than 34 weeks, definitely it can be delivered. We no need to give any corticosteroids to the patient, right? Option C says give injection magnesium sulfate for prophylaxis. Definitely we know that the patient is at a risk of eclampsia and she can throw seizures at any point of time. So definitely magnesium sulfate would be given as prophylaxis, but it is not the definitive management. Definitive means the best management with which you can save the patient. Start IV labetalol. Again, the patient is having severe preeclampsia. That means definitely she would be having a very high blood pressure. There would be hypertensive crisis in this patient. So IV labetalol can be given in this patient for hypertensive crisis, but it was not the definitive management. If I talk about some important conditions, how to differentiate it very fast. First of all, if the patient is having elevated blood pressure in the first trimester of pregnancy till 20 weeks of pregnancy, it would be called as a pre-existing hypertension. But if a patient is diagnosed with hypertension after 20 weeks of gestation, if the patient is having elevated BP that is more than equal to 140, by 90 mm of Hg, okay, after 20 weeks of gestation, then it is called as hypertensive in pregnancy, or gestational hypertension we can call it. Okay, it is also called as gestational hypertension, right? Then along with that, please remember, along with hypertension, if the patient is also having protein loss in the urine, that means there is proteinuria in the patient. Okay, that means more than 300 mg protein loss in a day, or more than 1+ on a urine dipstick test. Okay, if anything of that is there, then it would be diagnosed as preeclamptic toxemia, which was previously known as pregnancy induced hypertension. Then if along with all these features, that is hypertension plus proteinuria, the patient also has features of end organ damage. And what do we mean by end organ damage? The patient will have cerebrovisual symptoms. That means the patient will complain of headache, there would be nausea and vomiting in the patient, there would be blurring of vision in the patient. Okay, there can be oliguria, decreased urine output in the patient, all of these. So definitely that would be diagnosed as imminent eclampsia. That means the patient can have eclampsia at any point of time. Imminent means you cannot avoid it. Okay, and eclampsia, when with all of these, okay, with all of these features of hypertension, proteinuria, and organ damage, if you have GTCS in the patient, that is generalized tonic-clonic seizures, then it would be diagnosed as eclampsia. What is the drug of choice for eclampsia? All of us know. If they ask you for prophylaxis or for treatment of eclampsia, the answer remains same. It is magnesium sulfate. Is it given IV or IM? So please remember, we prefer giving it according to the Pritchard's regime. Magnesium sulfate is given according to the Pritchard's regime, right? So both, yes, very good. It is given IV 4 gram usually as a slow infusion, and it is given IM 10 grams. Okay, it is given IV 4 grams as slow infusion, and IM 10 grams it is given, 5 grams on each buttocks it is given, right? So this is known as IM plus IV regime, that is Pritchard's regime of magnesium sulfate. What is the therapeutic level? Because as we know, magnesium sulfate is a toxic drug, so we need to measure the levels. Very good. It is 4 to 7 milliequivalents per liter. It is 4 to 7 milliequivalents per liter. If the magnesium sulfate level goes beyond 7 milliequivalents per liter, then there would be magnesium sulfate toxicity. Okay, so please remember, if it goes beyond 7 milliequivalents per liter, there would be magnesium sulfate toxicity. And what is the earliest sign or earliest feature of magnesium sulfate toxicity? The earliest feature, yes, definitely. To reverse magnesium sulfate toxicity, the drug of choice would be calcium gluconate, 10%. Earliest, very good. It is loss of reflexes. Okay, loss of knee jerks or loss of deep tendon reflexes is the first sign or the earliest sign in cases of magnesium sulfate toxicity. If it increases further, then there would be respiratory compromise, then there would be respiratory depression, and if the level goes to almost 25 to 30, then the patient will have cardiac arrest. Okay, please remember this. So these are important. I hope I answered the question right. In eclampsia, the definitive management, in HELLP syndrome, definitive management is always and always immediate termination of pregnancy. Okay, please remember this. Usually we perform cesarean section. We do not ask the patient to go definitely into a normal vaginal delivery, and we do not induce labor in these patients. Okay? Question number 14. And overweight hirsute woman. I hope all of you are quite aware of what hirsutism is. Excessive facial hair growth is known as hirsutism. An overweight hirsute woman of 28 years with one child presented to the family planning clinic for advice of contraception. The best suited oral contraceptive will contain the following. So what is your diagnosis? It cannot be PCOS because we are not sure. Definitely there are symptoms of hyperandrogenism, that is hirsutism is seen, but there are no symptoms of others as such. Like definitely overweight is also there. Rotterdam's criteria is fulfilled, but we cannot suspect until and unless we have definitive other tests for it. Okay, we can suspect it as PCOS definitely. So definitely she needs some advice of contraception. Okay, here they have not mentioned amenorrhea or oligomenorrhea, which is actually a feature of what we can say PCOD. Okay, so here she needs rather contraception because she has already a child. Now she needs contraception. What should be there? So talking about contraception, because this is again important. If I talk about interception, guys, interception means emergency contraception. Okay, interception means emergency contraception or post-coital contraception. That means after unprotected sexual intercourse, which type of contraceptive method that you will use. The drug of choice for interception is definitely levonorgestrel. That is your progesterone only pills. 0.75 mg, 2 tablets are given. 0.75 mg, 2 tablets are given. Okay, within a period of how much? After an unprotected sexual intercourse, within a period of 72 hours they are to be given. Okay, within a period of 72 hours. But what is the most effective method? The drug of choice is definitely LNG pills or POP pills, but the most effective method is usually intrauterine contraceptive device. That is your IUCD, because it is maximum effective up till 5 days, right? It is effective up till 5 days after an unprotected sexual intercourse, right? This is important. Most common side effect of IUCD. Most common, these questions have been asked as one-liners. Most common side effect of IUCD is usually bleeding, whereas the most common cause of removal of IUCD is usually pain. Please remember this. Yes, ulipristal also can be useful up till 5 days, but IUCD is preferred over ulipristal or ELA. Okay. Pregnancy with IUCD. If there is a patient who is pregnant and having IUCD in situ, okay, it is SPRM, not a SERM. It is a selective progesterone receptor modulator. Okay, please remember. SERMs are drugs like raloxifene or tamoxifen. Okay, pregnancy with IUCD, no worries. Pregnancy with IUCD in situ. That means she already had a IUCD in situ and now she is pregnant. What should be your advice? So this was the question multiple times. What should be our advice? The first thing that you will do is actually remove the IUCD. The first thing that you will do is remove the IUCD. And secondly, it depends on the patient's wish. Either she wants to continue the pregnancy or she wants to terminate the pregnancy, which would be done by medical termination of pregnancy, right? So it depends on her. You will counsel the patient properly, and depending on that, you will perform. If there is a lost device, that means the thread of the IUCD is missing. In this case, definitely you can perform an X-ray or IUCD, or an ultrasound in the patient and can locate the thread of the IUCD. Okay, and then you will remove it. What is the so now answer these questions really fast. Answer these questions really fast. Contraceptive method of choice in STDs, sexually transmitted diseases. Contraceptive method of choice in sexually transmitted diseases. Fast. These are important from PSM point of view as well. Very good. These are barrier methods of contraception. That is something like condoms. Okay, along with spermicidal jelly. Then contraceptive method of choice for lactational amenorrhea. Lactational amenorrhea. For lactational amenorrhea, it would be pills. That is progesterone only pills. That is your LNG pills again. For newly married couples, contraceptive of choice for newly married couples, guys. Very good. It would be your COCPs, that is combined oral contraceptive pills, which will contain ethinyl estradiol and levonorgestrel, both of them. Then contraceptive of choice in couples living in separate cities. If they are meeting once in a while, separate cities. It is IUCD. Very good. It is IUCD. Contraceptive of choice in patients of heart diseases. In patients of heart disease, again IUCD. Very good. Because COCPs are contraindicated in patients of heart disease because it will lead to volume overload and heart failure. Whereas overall best method of contraception, least chances of failure, least Pearl index among all. Not IUCD, better. Sterilization. Okay, and the best one out of them is non-scalpel vasectomy followed by tubectomy, right? Please remember. So this should be your answers. Okay, moving further back to our question. So the patient is definitely a young patient, newly married couple. Okay, presented to clinic for contraception advice. Best suited oral contraceptive would be. Let's rule it out one by one. It is not emergency contraception. Okay, definitely. So levonorgestrel is out of choice. It is not in lactation. The female is not in lactation, and they are also not talking about just a minute. And they are also not talking about emergency contraception. So levonorgestrel is out of choice. Option B says ethinyl estradiol, which is usually 30 micrograms, and levonorgestrel, which is 150 micrograms. Doses are important. This is usually the component or structure of your combined oral contraceptive pills. These would have been the best choice if they would not have mentioned these other questions, the other features, like the patient is overweight and there is hirsutism in the patient. Then definitely we would have preferred COCPs in this patient because she is a young, newly married female, right? But in this condition, we will actually prefer option C, ethinyl estradiol along with cyproterone acetate. Why? Because please remember, cyproterone acetate is actually an anti-androgenic molecule. Okay, it is an anti-androgenic molecule. And as we know, for hair growth, whether in males or in females, irrespective of the sex, for hair growth, only one hormone is responsible, and that is androgens. That is your dihydroepiandrostenedione, right? So androgens are responsible for hair growth, and therefore in this patient there would be high levels of androgens that is causing hirsutism. Therefore we will prefer giving an anti-androgen like cyproterone acetate in this patient. So first line would be ethinyl estradiol along with cyproterone acetate. Yes, it is one of the first line agents in PCOS as well. Whereas option D, that is medroxyprogesterone acetate 150 milligram, it is famous by the brand name Antra, and it is a long lasting or a DEPA contraceptive which is used every 3 months. Okay, injectable hai, and it is given every 3 months in the patient, right? So I hope this was lag ho raha hai voice. I hope it improves a bit. Let me know if the voice is lagging. Question number 15. A diabetic female, 38 weeks, was admitted for normal vaginal delivery. After a normal head delivery, shoulder dystocia was diagnosed. The following maneuver was performed. What is the maneuver named as? So this was okay. So I hope we'll cope up with it somewhat. Okay. So definitely they are mentioning a diabetic female. That means one of the complications here would be macrosomia in the child. Okay, there would be a large baby more than 4 kgs, and usually with macrosomia, one of the common complications that is seen during delivery, if we are performing a normal vaginal delivery, the shoulder will get obstructed at the level of pubic symphysis. Okay, the shoulder is obstructed at the level of pubic symphysis or the pelvic outlet, and this is called as shoulder dystocia. So shoulder dystocia was diagnosed in this patient. So which of the following maneuver would be performed? The image has been given. You know, identify this maneuver. So very good. So the first or the most important maneuver that we perform in cases of shoulder dystocia is this one, when we will flex the lower limb. Okay, there would be flexion at the knee as well as flexion at the hip joint. Okay, along with that, a suprapubic pressure would be applied, not a fundal pressure. Fundal pressure is applied in NVDs, usually over here at the fundus, but it is contraindicated in cases of shoulder dystocia. It is the suprapubic pressure which is applied, and then we will also flex the knee. This together is known as the option D, Mack-Roberts maneuver. So this one is the first maneuver performed in cases of shoulder dystocia, guys. If I talk about the other maneuvers which are performed usually to deliver a patient having shoulder dystocia, the most common that we discussed is Mack-Roberts maneuver. If the baby is not delivered by it, then we perform a Woods corkscrew method or a Woods corkscrew maneuver. Then we will insert our hands into the vagina and we will move the baby. Okay, we will move the baby to the other side and we'll remove the hand from the posterior roomy vagina, because posteriorly there is no bone, right? There is no bone obstructing over here. So therefore we will remove the shoulder from the posterior roomy vagina by turning the baby. And this is known as the Woods corkscrew method. Okay. Next, if the patient is still not delivering, then definitely we can perform this Gaskins maneuver, right? This Gaskins maneuver, the patient is asked to go in the knee chest position, and as she goes in knee chest position, the pelvic outlet usually widens up and that can easily deliver the child. And lastly, if even not in this position, then we will perform a Zavanelli restitution with a cesarean section. Okay, what we'll do, we will insert our hand into the vagina, push the head back of the fetus into the vagina and deliver the child immediately with the help of a lower segment cesarean section. This is known as Zavanelli's restitution with cesarean section, which is the last resort of shoulder dystocia, right? So I hope all of these things were clear to you. Moving further, guys. And in shoulder dystocia, please remember one or two most important things. Which is the most common bone to be fractured in shoulder dystocia? Most common bone to be fractured. These are the neonatal complication. Most common, very good. It is the clavicle. And apart from that, there would be nerve plexus injuries. There would be injuries to the nerve plexus. That is your brachial plexus would be injured. That means there would be risk of Erb's palsy or Klumpke's palsy in this child. Right? Please remember this. Okay, Erb's palsy or Klumpke's palsy in this child. Very good, very good. All of you are right. Moving further, guys. Question number 16. A pregnant female presented to the emergency with complaints of abdominal pain and vaginal bleeding. On examination, the cervical os was closed. No prolapse of products of conception was seen. Fundal height is corresponding or equal to the gestational age. What is the likely diagnosis? So a pregnant female, if she is bleeding, definitely, and having abdominal pain, one of the likely complications can definitely, or one of the differential diagnosis definitely is abortion. Right here, all of the things are abortion. Definitely, we are suspecting abortion in this patient. So how to differentiate all types of abortion? You need to remember three things. Okay. First of all, check for the cervical os. Second, check for the prolapse of products. If there is any prolapse of products of conception. And third, important, you need to check the fundal height or the uterine height in this condition. Right. Let's rule it out one by one. Incomplete abortion, the cervical os in this condition would be open. Right. Prolapse, yes, there would be a history of prolapse. Along with that, there would be presence of products prolapsing out. That means now also when you are checking the patient, there are some products which are coming out of the vagina, and she also tells you that some products have already been gone out. Okay, so that means history as well as presence of products of conception prolapsing out from the vagina, and fundal height would definitely be decreased or less than the normal gestational age. Okay, complete abortion, the cervical os would be closed. Now the abortion has been completed. Here, prolapse of products would be there. History of prolapse of products would be there. She tells you like almost all of the mass have been like gone out. And if I talk about the fundal height, it is equal to the non-pregnant size of the uterus. It becomes non-pregnant, equal to the non-pregnant size of uterus. If they say, if the cervical os is closed again, okay, there is no history of prolapse of products or no prolapse of products is seen, and the fundal height is equal to the period of gestation, which is the case in our question. It is option C, threatened abortion. So you can see the cervical os was closed, no prolapse of products or no history of prolapse of products, and the uterine height or the fundal height is equal to the period of gestation. It is threatened abortion. Okay. Whereas inevitable abortion, that means abortion can occur at any time. Here the cervical os would be open. There would be bulging out products of conception. Okay, the products will be bulging out from the os, and the fundal height, it can either be normal or it can be decreased as well. Okay, so please remember this. I hope this was easy for all of you, the different types of abortions. Can anybody tell me, for abortion, usually during the first 7 weeks, what is the best method for medical termination of pregnancy? According to the new amendment, everybody knows it is till 24 weeks of gestation. It can be performed till 20 weeks, one doctor opinion, till 20 to 24, two doctor opinion, all of that you know. Till 7 weeks, usually we prefer medical management. And first we give mifepristone to the patient, which is Ru486, antiprogestin to kill the fetus. And after that, on the 3rd day, usually we give misoprostol to the patient, which will induce contraction, and that will lead to expulsion of the fetus, right? So this is the medical management. This can be performed up till 9 weeks, but it is only preferred up till 7 weeks in India. Okay, from 8 to 12 weeks, the best method is, yes, 200 200 milligrams of mifepristone is given, and 400 micrograms of 200 mg and 400 mcg. Okay, the dose has been asked. Maximum dose of misoprostol which is given vaginally, it was around 800 to 1000 mcg. That means each tablet is 200 mcg, so at least 4 to 5 tablets maximum can be given. August ka question tha. Between 8 to 12 weeks, no. Dilatation and curettage can be performed. Better technique is suction and evacuation. And the question was, suction and evacuation ke liye which cannula was used? Which cannula is used for suction and evacuation? Vaginally also we give it, rectally also we give it usually. Okay, orally also it can be given, but definitely we will prefer vaginally or rectally in this patient. During delivery, to prevent PPH, we give it rectally. Okay? Yes, very good. It is the Carmen's cannula. Okay, it is the Carmen's cannula, please remember. And the size of Carmen's cannula which is used, it is equal to the period of gestation. This was a question. 8 weeks of gestation, 8 number of cannula. 10 weeks of gestation, 10 number of cannula. Okay? And after 12 weeks, that is after first trimester, we usually use prostaglandin analogs like misoprostol. These are the preferred techniques. Apart from that also, we can use other methods, but these are the preferred ones. Question number 17. A lady suffering from diabetes mellitus delivered at term, an infant of diabetic mother is at risk of all of the following except for. This was easy for all of you, I hope so. So first thing, let's rule it out one by one. Very good, guys. I hope you are quite aware that if a patient is having diabetes mellitus, there would be maternal hyperglycemia, right? There would be increased levels of sugar in mother, right? Along with maternal hyperglycemia, that would also reflect in the fetus. So there would be fetal hyperglycemia, right? There would be fetal hyperglycemia. And whenever the child is getting enough of food or enough of nutrition, whenever you are in a luxurious mood, you are not mature. Okay, so please remember, whenever you have a childhood full of struggles, then definitely you mature early. Okay, but whenever you have a lavish lifestyle or a luxurious lifestyle, okay, you are getting excess of everything, definitely will not mature until 40 weeks also. So definitely please remember, in cases of diabetes mellitus, the scenario is same. The fetus is getting excess of glucose or excess of nutrition, so therefore there is inadequate surfactant production. Okay, and the patient or the child would suffer from respiratory distress syndrome even at 40 weeks. Therefore, even if we are delivering a diabetic mother at 40 weeks, we try to give corticosteroids to accelerate the lung maturation, because there is surfactant deficiency which is noted in infants of diabetic mother. So this is definitely a complication. Option C says hyperbilirubinemia. Yes, in cases of diabetes mellitus, there is polycythemia. Excess of RBCs will break down, that will lead to hyperbilirubinemia. And caudal regression syndrome, as all of you know, here they have not mentioned whether the patient was gestational diabetes mellitus or a pre-existing one. So here, as they have given one of the congenital anomalies, definitely we will suspect that the patient would have a pre-existing diabetes mellitus, and caudal regression syndrome or sacral urgenesis is one of the gross congenital anomalies associated with infant of diabetic mother. Hyperglycemia, why did I rule out? Please remember guys, I have said there is fetal hyperglycemia, and here I am asking you, an infant of diabetic mother is at the risk of following. Okay, so please remember, during pregnancy, what has happened? There was maternal hyperglycemia, therefore there was fetal hyperglycemia, and therefore the pancreas of the fetus, that is your beta cells of pancreas of the fetus, were usually secreting excess amounts of insulin. Hyperinsulinemia was there. But even after delivery, what happens now? This hyperglycemia component is gone, because the fetus has been separated from the mother, right? But the insulin secretion is still high, and this excess of insulin secretion will rather cause a hypoglycemia in the neonate. So please remember, it is fetal hypoglycemia, but a neonatal hypoglycemia. Fetal hyperglycemia, but a neonatal hypoglycemia. This was a question, you need to remember this. Okay, please remember. Here I have asked you about the infant or the neonate, not about the fetus. If I would have asked you about the fetus, definitely your answer was correct. Hyperglycemia can be one of the complications. As we know, with pre-existing or over diabetes mellitus in a mother, there is risk of gross congenital anomalies, which is the most common gross congenital anomaly in an infant of diabetic mother. Important question from PD and Ops both. Okay, most common gross congenital anomaly in an infant of diabetic mother. Please remember, yes, very good. These are the cardiac defects. Usually these are the cardiac defects, and out of the cardiac defects, the most common one would be a ventricular septal defect, but the most specific one would be a transposition of great arteries, that is your TGA, right? This is important. Very good. Most common VSD, most specific cardiac anomaly, transposition of great arteries. If they ask you the most specific gross congenital anomaly overall in a patient of infant of diabetic mother, they have not mentioned a cardiac anomaly. Which is the most specific? Most common are definitely cardiac anomalies, but the most specific overall, very good, it is sacral urgenesis, also called as caudal regression syndrome, where the lower limbs of the fetus would not be formed, okay, or lower limbs of the child would not be formed. Sacral urgenesis or caudal regression is the most specific overall congenital anomaly associated with infant of diabetic mother. Maternal complications are remembered as P. Usually during diabetes, as we discussed already, the patient will have polyhydramnios, excess of amniotic fluid. This will lead to premature rupture of membranes in the patient, and that will land up the patient in a preterm labor. So all pre's to be remembered for this. Okay, and there can also be infection. Therefore, chorioamnionitis is also one of the complications. Moving further, question number 18. A pregnant female presented to the labor room with complaints of headache, blurring of vision, nausea, and vomiting. Her blood pressure recording was 170 by 100 mm of Hg. She gives history of decreased urine output and urine dipstick shows 2+ proteinuria. She was admitted and immediately she started convulsing. The next best step in the management is, so guys, I hope all of you are at least able to make the provisional diagnosis, right? If they would have just said elevated BP more than 170 by 100, then it would have been preeclamptic tox, like it would have been usually hypertensive crisis. Along with that, they have mentioned proteinuria. That means it becomes preeclamptic toxemia. Along with, they have also mentioned about end organ damage like headache, blurring of vision, nausea, vomiting, and decreased urine output, that is oliguria. So end organ damage is present, definitely it is imminent eclampsia. But now when she was admitted in imminent eclampsia, she started throwing convulsions. So now the patient is also having generalized tonic-clonic seizures. So the provisional diagnosis here becomes eclampsia. And what is the next best step? Please remember, in cases, the first step or the next best step in cases of eclampsia would not be giving a IV or IM magnesium sulfate. It would always be airway management. Yes, it would always and always be basic resuscitation. Okay, please remember, airway, breathing, and circulation, ABC are managed first. And for airway, usually we can definitely use the Goodell's or oropharyngeal airway. So airway management is the next best step. Please remember, if they would have asked you about the best step, that would have been termination of pregnancy. Best or definitive step is definitely termination of pregnancy. Next best step or the first step is definitely airway management or basic resuscitation. IV or IM magnesium sulfate is the drug of choice. Okay, it is not the next step or the best step overall. Please remember, IV labetalol is also given around 20 mg for the hypertensive crisis component. Okay, it is an alpha plus beta blocker. Okay, if that is not an option, definitely you know now from December the other choice to be used is alpha methyl dopa. Okay, it is the safest antihypertensive drug in pregnancy. Okay, labetalol is the drug of choice, but apart from that, if that is not an option, alpha methyl dopa should be another answer. Okay, and in case of hypertensive crisis, first choice is definitely IV labetalol. Okay, but if it is not an option, the second choice should be IV hydralazine. Okay, hydralazine is only given in cases of crisis. Usually in maintenance, we prefer it after methyl dopa, not before methyl dopa. Please remember this. 17 का answer B है. Yes. Option question number 19. A 38-year-old pregnant multiparous woman is presenting with history of recurrent bleeding. On examination, she is diagnosed as a patient of placenta previa with the following type of placental extension. The type of placenta previa in this patient is. So I hope all of you are quite aware what is placenta previa, a low-lying placenta. Usually it is in the upper segment, but if the placenta is in the lower segment of the uterus, it is considered as a low-lying placenta or placenta previa. So there are total 4 grades. Grade 1, when there is a low-lying placenta only dipping into the lower segment. Grade 2, when there is a marginal placenta previa. That means it is at the margin of the internal cervical os or more than 2 centimeters away from the os. More than 2 centimeters away from os. Third, grade 3 is a partial placenta previa or an incomplete placenta previa when it is partially covering the internal cervical os, but it would move away during cervical effacement. And grade 4 is the most severe type of placenta previa when it is completely covering the cervical os. Okay, that is complete of grade 4. So please tell me the type of placenta previa. Here you can see it is not partial. First of all, it is not only lying in the lower segment, but it is also at the margin of the internal cervical os. It is not covering. Usually, if it is covering the partial cervical os partially, then it would have been something like this. Okay, so it is option B, type 2 placenta previa. It is type 2 placenta previa in this condition. Okay. Question number 20. The lady has history of previous 2 abortions, and as a part of fetal surveillance in this pregnancy, umbilical artery Doppler was performed at 32 weeks of gestation, and it is given below. What is the management in this condition? So what are you suspecting from this umbilical artery Doppler? So apart from the biophysical profile, definitely we will check for the fetoplacental flow, whether the fetus is getting the blood supply or not. That is done with the help of an umbilical artery Doppler. These 3 images are important to remember. As we know, blood supply from placenta to the fetus is maintained both during systole as well as diastole. So there would be a systolic flow as well as a diastolic flow to the fetus. So this is actually a normal umbilical artery Doppler. Okay, there is a maintenance of flow in systole as well as diastole. In the second image, you can see during systole, definitely there is a fetal flow, but during diastole, there is an absent diastolic flow, right? So absent diastolic flow is seen in the second image. So absent diastolic flow mein, it is suggestive of placental insufficiency. So please remember, it is suggestive of placental insufficiency, right? And the third image, here you can see during systole there is blood supply to the fetus, but during diastole rather the blood is pulled back from the fetus. So there is a reversal of diastolic flow. There is a reversal of diastolic flow. And reversal of diastolic flow, please remember, it is suggestive of imminent death of the fetus, imminent intrauterine death of the fetus. So anytime the death of the fetus can occur if there is a reversal of end diastolic flow. Definitely, if it is reversal of end diastolic flow, usually you need to immediately terminate the pregnancy. You need to terminate the pregnancy irrespective of the gestational age, whether it is 32 weeks, whether it is 34 weeks, or at term. In the second case, as you can see in our image also, which was given in question, systolic flow is maintained, but diastolic flow is absent. So it is actually this type 2 absent diastolic flow is seen in the patient. That means there is a placental insufficiency in this child or in the fetus, right? In this condition, if the patient is 34 weeks or more, then you can deliver the child. Okay, if the patient is more than 34 weeks, definitely you can perform termination of pregnancy. But if, as in our case, the patient is at 32 weeks of gestation, there is lung maturity has not occurred properly, so definitely we will try to actually prolong the pregnancy as much as possible. If it changes to reversal of diastolic flow, we need to terminate it, but at least we'll try to prolong it till the 34 weeks, so lung maturation can occur properly. So immediate termination of pregnancy would not be done because she is less than 34 weeks, first thing. Option B says normal Doppler, so continue pregnancy till term. No, it is not a normal Doppler, so it should not be done. Corticosteroids and fetal monitoring, yes, option C would be your correct answer. Corticosteroids should be given for accelerating the lung maturation, and continuous fetal monitoring is done. Okay, if on fetal monitoring at any time, if there is reversal of diastolic flow, you need to terminate the pregnancy. Okay, otherwise you can continue it till at least the next 2 weeks, that is 34 weeks, and then you can deliver the patient, right? Induced labor with oxytocin, no, please remember, usually during oxytocin, what will happen, there would be intrauterine contractions, and that will compress the umbilical cord, and the fetal blood flow would be impaired even further. So definitely NVD would not be performed, rather we will try to perform a cesarean section in this patient, right? Question number 21, guys. A 30-year-old primipara, that means first time the pregnancy went beyond 20 weeks, attends the antenatal clinic at the period of amenorrhea of 35 weeks. That means the gestational age is 35 weeks. She has a single fetus in breech presentation. Ultrasound scan confirms the presentation that it is breech. No other abnormalities are detected. What is the next step in the management of a normal vaginal delivery? So what should be done in this condition? 30-year-old primipara woman, 35 weeks of gestation, she comes to you. She has a single intrauterine fetus, but it is in breech presentation, confirmed by ultrasound. No other abnormalities are there. What should be your answer? Very good. Option A says induced labor if not delivered by 40 weeks. Definitely we will not try to, like, this would be a good option, but not suitable over here. First thing. Second, option B, perform an elective cesarean section at 39 weeks. Why to perform an elective cesarean section? Okay. So though she is having a breech presentation, we can still work on it, as we have discussed already. We can perform an external cephalic version. We can try to rotate the baby. Okay, externally, external cephalic version can be performed at 36 weeks. Okay, and we can turn the baby to a cephalic presentation and can deliver the baby via normal vaginal delivery. Artificial rupture of membranes is not done. Okay, at this time we are not delivering the patient. We will deliver the patient at term only, but right now we will perform an external cephalic version to make it cephalic. Okay. Where is internal podalic version performed? Internal podalic version, we will try to catch the legs of the baby and make it cephalic. It is usually done in the second twin. Okay, after the first twin is delivered, we will deliver the second breech via internal podalic version. During delivery, it is performed. So usually around 36 to 37 weeks. Usually in primipara, as they have mentioned in the question, it is around 36 weeks, whereas in multipara, it can be done at 37 weeks. Okay? So at 37 till 37 weeks, because after that the volume of amniotic fluid decreases. Question number 22, guys. G3 female with previous second trimester abortions presents with 22 week of gestation, abdominal pain, ultrasound shows funneling of the internal os. What is the ideal management? So here they have given she is 3 times pregnant. First, there were 2 second trimester abortions in the female. Now she is presenting to you again in the second trimester at 22 weeks of gestation and complaining of abdominal pain. When we are performing an ultrasound, there is funneling of uterus. So this is the normal shape of the cervical os, that is T shape. But when the funneling begins, okay, that it will turn into a Y shape, then into a V shape, and then into a U shape. Okay, and that can lead to labor in this patient and expulsion of fetus can occur. That will cause abortion in this patient, right? So here actually the patient is having second trimester abortion history. As we know, the most common cause of abortion, please tell me. Most common cause. I know all of you know the answer, just I'm trying to cover all the other points as well. Because if we are revising ops, it is important we revise it thoroughly. Otherwise, there's no use of me coming over here. Where most common cause overall, it is not anatomical. Please remember, most common cause of abortions, overall, the answer should be very good. It is chromosomal abnormalities. The answer should be chromosomal abnormalities. If they ask you most common cause of abortion in first trimester, again the answer would be chromosomal abnormalities. But if they ask you the most common cause of abortions in the second trimester, the answer then will change to uterine defects. The answer will change to uterine anomalies or uterine defects. Mullerian defects like septate uterus or a bicornuate uterus which cannot hold the pregnancy beyond 22 weeks, or the most common cause actually overall in uterine defects, it is actually a short cervix. As we know, the normal length of the cervix should be 3 to 4 centimeters. But if it is less than equal to or less than 2.5 centimeter, it is considered to be a short or an incompetent cervix. So, okay, that is one of the causes of second trimester abortion, rather the most common cause out of all. And whenever the patient is having abortion, along with abdominal pain or labor, there would also be funneling seen. Okay, and this is called as the preterm labor. So here the patient is having preterm labor, and causes of preterm labor are bleeding in POD. That means bleeding in the retrochorial space. IN goes for incompetent cervix or short cervix, which is the most common cause. P goes for pelvic inflammatory diseases. O goes for over distension of the uterus. Over distension means there would be a large baby or polyhydramnios or a twin pregnancy. That can also lead to preterm labor. And D goes for defects, like your uterine defects that we have discussed already, septate or bicornuate uterus. Prediction of preterm labor, it can be done with the help of ultrasound. As I told you, on ultrasound, we will be able to look for funneling, right? Funneling of the cervix can be seen. And second, a chemical can be noted in the vaginal secretions. This chemical is known as fetal fibronectin. If fetal fibronectin is seen less than 18 weeks and more than 37 weeks, it is normal. But if it is seen between 18 to 37 weeks, it is suggestive usually of, please remember, preterm labor. Okay, it is suggestive of preterm labor if it is seen between 18 to 37 weeks. Okay, so in this condition, the patient is having second trimester abortions recurrent. Now, again, she's having a second trimester abortion. Uterus is also confirming it by funneling of os. What should be the ideal management? The most common cause is short cervix. So here the management should be option C, option D, McDonald's cerclage or a McDonald's stitch should be applied to the cervix. Okay, so this McDonald's stitch, these first string sutures are applied to the cervix and it is closed. Okay, usually we will apply these McDonald's stitch more than 12 weeks and we will remove it after 37 weeks. Okay, at or after 37 weeks, we will remove this McDonald's cerclage or McDonald's stitch. Apart from that, definitely Shirodkar stitch can also be applied. Carboprost or mesoprost, definitely these are not given anyways, because they are rather they will induce uterine contractions. They will not stop them. Okay, rather for inhibiting preterm labor or the drug of choice for preterm labor, the tocolysis is given. And what is the tocolysis of choice? Very good. It is a calcium channel blocker like nifedipine. It is calcium channel blocker known as nifedipine. Okay, please remember this. Very good. Moving further, question number 23. A primigravida, 37 weeks of gestation, reported to the labor room with marginal posterior placenta previa with painless bleeding per vaginum. The fetal heart rate was normal at the time of examination. The best management option for her is, so if I talk about placenta previa, important scenarios only. If a patient is having a low-lying placenta or a placenta previa and she presents to you with bleeding, okay, she presents to you with a bleeding placenta previa at less than 34 weeks. Lungs have not matured, so definitely you cannot deliver this patient. So the better management would be a expectant management or a conservative management. Now, what is this regime known as? Anybody? What is this expectant or conservative management known as? This is important. The conservative or expectant management in a patient of placenta previa who is bleeding less than 34 weeks, it is known as, anybody? McAfee and Johnson regime. This McAfee and Johnson regime, here we will try to resuscitate the patient, then sedate her, give her, advise her bed rest, and give her corticosteroids. If in any case we need to deliver the patient earlier, so at least there would be fetal lung maturation which would occur with the help of corticosteroids, right? If the patient of placenta previa comes to you at term, okay, but here she is bleeding, definitely will perform a delivery, okay? So please remember, at term, if the patient presents with placenta previa which is bleeding, and as we know, in placenta previa and vasa previa there is painless bleeding, in abruptio placenta there is a painful bleeding. Important. So here, which type of delivery would be performed? Very good, it is cesarean section, okay? And term, if the patient presents to you with bleeding, if there is bleeding at term, definitely cesarean section is indicated. If the patient of placenta previa is not bleeding and presents to you at term, that is at around 37-38 weeks, then we will assess the patient, which grade she is. If it is grade 1, then definitely the placenta might have moved upward already and a normal vaginal delivery can be performed. If it is grade 4, completely covering, it will not move at any case, therefore a cesarean section would be indicated. Okay. Grade 3 and grade 2 and grade 3 are important. In grade 2, we need to check whether it is an anterior marginal placenta previa or a posterior marginal placenta previa. If it is anterior, definitely a normal vaginal delivery can be performed. But if it is posterior, guys, please remember, due to the head of the fetus, this placenta would be compressed and there can be bleeding, excessive bleeding in this patient. Therefore, in posterior, you actually try to perform a cesarean section. And if it is grade 3, guys, you will perform a double setup examination. That is a per vaginal examination is performed in the OT. And if you have a 10 centimeter margin on both the sides of the uterus or the os, okay, 5 centimeter on this and 5 centimeter on this, so the biparietal diameter can fit in it. So definitely you can deliver the patient via a normal vaginal delivery if it is more than 10 centimeter margin. But if it is less than 10 centimeter, then you need to perform a cesarean section. So here, please tell me, primary gravida 37 week, labor room mein aayi hai, marginal, that means type 2 placenta previa and it is posterior, painless bleeding per vaginum, the fetal heart rate was normal, so there is no fetal distress as such, best management option for her. So very good, it should be cesarean section. Why? First thing, she comes to you at term. So irrespective of the grade of placenta previa, the management, if she is bleeding at term, the answer should always and always be cesarean section. Second, they have also given it is a type 2, that is marginal posterior placenta previa, and that we discussed. In type 2 posterior marginal placenta previa, it is cesarean section always. So the answer remains C section. Question number 24, guys. A pregnant lady at 32 weeks of gestation presents with painful bleeding per vagina. So if it is painful bleeding between 28 weeks till delivery, then it is definitely a abruptio placentae. Then if it is definitely abruptio placentae. So the diagnosis of abruptio placentae, let's confirm it further. 32 weeks pe, painful bleeding. On palpation, tenderness is noted. Definitely there would be pain on palpation of the uterus. Which among the following is not employed or not used in the management of this patient? So let's see it one by one. Option A says basic resuscitation. Yes, the first step, if the patient is having abruptio placentae, should be basic resuscitation. Whether it is bleeding placenta previa or a bleeding abruptio placentae, the first step is always and always basic resuscitation, that is ABC, should be taken care of. Option B says injection dexamethasone 6 mg 12 hourly 4 doses, right? We use dexa or betamethasone, so it is 6 mg 12 hourly 4 doses of dexamethasone. It is definitely given because see the gestational age, it is 32 weeks, less than 34. Lung maturation has not yet occurred, so definitely we will use this. Option C, injection nifedipine for tocolysis. So if we give injection nifedipine and cause tocolysis, that is uterine smooth muscle relaxation, the blood vessels would not be compressed and rather there would be excessive bleeding and there would be worsening of bleeding. So no tocolysis is given in cases of placenta previa or in cases of abruptio placenta. In both the conditions, tocolysis is contraindicated. So this is definitely not an option. Whereas option D says add oxytocin and perform a artificial rupture of membranes. Definitely, as we know, the best management for abruptio placentae, irrespective of the gestational age, whether it is 32 weeks, 34 weeks, or term, always and always it is artificial rupture of membranes and perform a normal vaginal delivery. And for inducing labor or for helping labor, we can give injection oxytocin as well, because it causes smooth muscle contractions. When do we perform C-section in abruptio placentae? Only and only when there is fetal distress. Okay, abruptio placentae is not an indication of cesarean section. In abruptio placentae, we perform ARM and deliver normally. But if there is fetal distress in the child, then definitely we need to perform a cesarean section. And fetal distress is said when the fetal heart rate drops down to less than 110 beats per minute, or if the fetal scalp blood pH is less than 7.2. These are the only two terms when we call it as a fetal distress. Otherwise, decreased fetal movement count or not feeling cardiac, you cannot hear the cardiac activity, all of these are not fetal distress. Question number 25. A young female came for counseling before conception. All below given conditions are contraindications to pregnancy except conception ke pehle she comes to you for counseling purpose. All of the following are contraindications to pregnancy except. Option A says Eisenmenger syndrome. I hope all of you are quite aware. If a patient is having a congenital heart disease like ASD, a cyanotic heart disease, right? Okay, or VSD we will talk about, which is most common. In VSD, usually there is shunting from high pressure to low pressure. That means from left side to right side. So oxygenated blood mixing with deoxygenated blood, no problem, right? As such. But at a point, what happens? The right sided pressure increases so much and it exceeds the left side pressure. So now there is reversal of shunt. Okay, so there would be reversal of shunt and there would be a shunt from right side to the left side of the heart. So now the deoxygenated blood will mix with the oxygenated blood of the heart, and that will lead to a cyanotic heart disease, right? And therefore it is a contraindication of pregnancy. Rather, it is the most severe manifestation and pregnancy is absolutely contraindicated. Option B says Marfan syndrome involving the aortic root and causing aneurysm. Definitely, if there is aortic root aneurysm, there is a high risk of rupture. There can be bleeding in this condition. Because in Marfan syndrome, usually the collagen which is formed, it is usually weaker, right? So there is a high risk of aneurysms, and if it is involving the aortic root, it is increases further. So definitely it is also a contraindication to pregnancy. Primary pulmonary hypertension is also a contraindication to pregnancy because the pulmonary resistance is increased so much. And option D says coarctation of aorta is not a contraindication of pregnancy. Most of the books says coarctation of aorta is. Please remember, not all cases of coarctation of aorta is a contraindication. Only very severe cases of coarctation of aorta is a contraindication to pregnancy. Whereas if they only mention aneurysm, okay, if they only mention aneurysm, that is also not a contraindication. If that aneurysm is associated with Marfan syndrome or it is involving the aortic root, then and then only it is a contraindication. Otherwise, it is not. Okay? Answer is option D, guys. Sorry. Question number 26. A pregnant lady at 28 weeks of gestation presented to the OPD with complaints of heat intolerance, tachycardia, palpitations, and tremors. On ultrasound, IUGR, that is intrauterine growth restriction, was diagnosed in the fetus. Which among the following drug shall be initiated in this patient? What is the provisional diagnosis? I hope all of you are quite aware of these symptoms, endocrinal symptoms, heat intolerance, tachycardia, palpitations, tremors. So there is increased basal metabolic rate in this patient. That is due to increase in T3 and T4 hormones. So therefore, the diagnosis in this condition is hyperthyroidism in pregnancy, right? Hyperthyroidism in pregnancy. All of these features are of hyperthyroidism. And as we know, IUGR is one of the complications of hyperthyroidism. Hypothyroidism, not Shazad. Please remember, hypothyroidism usually the patient will have cold intolerance, mental confusion, obesity. Okay, so all of that would be seen. So it is hyperthyroidism in pregnancy. Which among the following drugs should be initiated? Which is the drug of choice for hyperthyroidism in pregnancy? Answer these one-liners fast. Drug of choice for hyperthyroidism in pregnancy. Drug of choice for hyperthyroidism in pregnancy. Very good. PTU, propyl thiouracil, which is an anti-thyroid drug. Very good. If I say drug of choice for hyperthyroidism in first trimester of pregnancy, yes, if it was hypothyroidism, definitely we would have given L-troxin, which is nothing but a levothyroxine analog. Okay? Yes, again it is PTU, because propylthiouracil is the safest anti-thyroid drug that we have, and during first trimester, during organogenesis, we avoid giving any teratogenic drugs to the fetus. So definitely it is PTU which is preferred. But if they talk about second and third trimester of pregnancy, here we will use the most effective drugs. And which are the most effective drugs for hyperthyroidism? These are usually carbimazole or methimazole. Very good. These are carbimazole or methimazole. But why do we avoid these drugs during the first trimester? Because they have very two important side effects. Okay. And these was asked in the question. Which two? Very good. Very good. That is cutis aplasia. That means the skin is not formed properly. And the second is choanal atresia. That is choanal atresia. These two side effects have been asked. Please remember. Okay. So carbi or methimazole are the best drugs for hyperthyroidism in pregnancy, but they cause teratogenic side effects like cutis aplasia and choanal atresia, therefore avoided in the first trimester. For hypothyroidism, the drug of choice would have been L-troxin. But as it is the but as it is hyperthyroidism, it should either be propylthiouracil or methimazole. Okay. Please remember, they are saying she is at 28 weeks of gestation. That means second trimester of pregnancy. So you would have seen this. Most of the people would have made a mistake by just seeing hyperthyroidism, pregnancy, PTU. Okay? Also see the gestational age. It is 28 weeks, so second or third trimester. So the better drug would be methimazole 20 mg. PTU 100 mg if they would not have mentioned about anything, or if they would have mentioned about the first trimester. Iodine 131, those who are answering, it is absolutely contraindicated during pregnancy. Why? Because radioactive iodine, actually, it will destroy thyroid gland. Okay, it will emit beta rays and it will destroy all your thyroid gland, and the patient will require lifelong thyroid supplementation. So it is absolutely contraindicated in pregnancy, and also in young adults. It only gives the 35 years of age. Question number 27. A pregnant lady who is a known epileptic was on carbamazepine therapy. This drugs belongs to which category of drugs? So I hope this was easy for all of you. Category A drugs are the ones which are really safe and can be given easily in the patients, that are multivitamin like drugs or thyroxine like drug. Category C usually category C drugs are teratogens in animals. Okay, they are teratogenic in animals, but we have limited human studies for them. Okay, and these are the majority of the drugs. Majority of the drugs like your antiviral or antibiotic drug, they come in category C. Category D drugs are usually anti-epileptic drugs like carbamazepine or phenytoin, okay, lamotrigine, all of these. So here, these are definitely known human teratogens. These are teratogens, but these are given if the benefits are more than the risk. Okay, if the benefits to the patient are more than the risk, then definitely we prefer giving these drugs, like carbamazepine is given also in a pregnant female, right? And category category X, these are the teratogenic drugs. Highest teratogenicity is seen in category X drugs. These are absolutely contraindicated during pregnancy. And these are drugs like vitamin A is contraindicated. Please remember, alcohol is definitely contraindicated. So that can cause fetal alcohol syndrome in the fetus, right? Apart from that, lithium is contraindicated. It leads to, please tell me the teratogenic side effect. Thalidomide is contraindicated, which is given in lepra reaction. Very good. Lithium, this has been asked multiple times. Lithium is associated with Epstein's anomaly, causing a box-shaped heart. And thalidomide is associated with phocomelia. That means the limbs would not be formed. See, like flippers would be there, just like this. Okay, please remember. Yes, alcohol will lead to fetal hydantoin syndrome. Very good. Warfarin. Okay, warfarin is absolutely contraindicated. Please remember this. Okay. If a patient is already on an anti-epileptic drug like valproate, and she's already pregnant, then definitely will not change the drug in between, because if you change the drug and she has seizures, there is a high risk that she can lose her pregnancy. So you will continue that drug even if it is teratogenic. Okay, only will add folic acid to it. Okay, only will add folic acid to it if she is already pregnant. Okay, otherwise if she comes to you before pregnancy, then definitely will stop a teratogenic drug 1 month before pregnancy, shift her to a more safer drug. And which is the safest anti-epileptic drug in pregnancy? Very good. It is levetiracetam, Levera, followed by lamotrigine. Okay, or sometimes they say lamotrigine is the drug of choice, but Levera is more safer as compared to lamotrigine in cases of pregnancy during like for epilepsy. Question number 28, guys. A patient came to antenatal clinic for routine visit. Level 1 scan was performed. So level 1 ultrasound or a level 1 scan is also known as the chorionicity scan. Okay. So this is only done to check for the type of, if there is not any twin pregnancy or if there is any like any ectopic pregnancy. Okay. So to check the status of the chorion and amnion. So level 1 scan, usually it is performed around, so this is important. It is usually performed around 11 to 13 weeks. Important. It is performed around 11 to 13 weeks. It was performed, which shows a nuchal translucency of 4 mm. So I hope all of you are quite aware. If on an ultrasound, we can measure the nuchal translucency. If it is more than equal to 3 mm, that is 3 mm or more, it is suggestive of chromosomal abnormalities in the fetus. It is suggestive of aneuploidies in the fetus. Right, it is strongly suggestive of aneuploidies in the fetus. So here it is 4 mm. Definitely we can suspect some aneuploidy. Therefore, the doctor recommended to perform a quadruple test in second trimester. So if I talk about chromosomal abnormalities, guys, which are also called as aneuploidy, it can be one more chromosome, that is called as trisomy, one less chromosome, that is called as monosomy. Right? So all of these are called as aneuploidies together. For that, the screening tests which are done is, the first one is usually ultrasound, on which we can check for the nuchal translucency. 3 mm or more is suggestive of aneuploidy. Apart from that, we also have a triple test or a quadruple test. Okay, when is quadruple test performed? It is usually performed at a period of 16 to 20 weeks. That is in the second trimester, as they have mentioned in our question also. Right? Please remember. But here, usually it was diagnosed on ultrasound itself that the patient is having some aneuploidy. Okay, so there is no need of a triple or a quadruple test again. Rather, we will send the patient for a diagnostic test. Okay, but sometimes the question comes like this, so you cannot help it. So after ultrasound or triple or quadruple test comes positive, any of one of them, then you will directly send the patient for a diagnostic test. In first trimester, you will perform a chorionic villus sampling for diagnosis. In second trimester, you will perform a amniocentesis. Please tell me the time when these tests are performed. Yes, after taking samples via CVS or amniocentesis, you will perform a karyotyping, which would be the best investigation out of all. Very good. Chorionic villus sampling is performed around 11 to 13 weeks in the first trimester, whereas amniocentesis is performed around 16 to 22 weeks, at least you can remember. Okay, 16 to 22 weeks. 16 to 18 is the best time. 16 to 22 is the whole range. Okay? So triple test, we have 3 components in it. Okay. First is unconjugated estriol, second is alpha fetoprotein, and third is beta HCG. Whereas in quadruple test, one more is added, that is inhibin A, right? And I hope they are talking which among the following is not a result of the positive test. Okay, usually please remember, high would be high. That means there would be elevated levels of beta HCG and there would be elevated levels of inhibin A. So that means both of these statements are correct. If beta HCG and inhibin A are high, that means the test is positive. Please remember, unconjugated estriol or alpha fetoprotein levels should be low, as we discussed already. And alpha fetoprotein levels are high in neural tube defect, but low in cases of trisomy. So here, the alpha fetoprotein levels and unconjugated estriol levels should be low. So the exception over here is option A. Increased unconjugated estriol is not a result of positive test. Okay, please remember this. So I hope it is easy for all of you. Right, this is important, guys. Don't forget it. Most common chromosomal abnormality during pregnancy are trisomies. Most common trisomy is trisomy 16, but the fetus is incompatible with life. Therefore, usually the most common in a living fetus would be, a living child would be, it would be Down syndrome. Okay, please remember. Question number 29, 29, guys. The patient went in a labor and for monitoring a cardiotocography was performed. I hope all of you are quite aware. The single best test which is performed for monitoring of labor is cardiotocography. It was performed and the finding has been given below. The cause for this finding is, what is the cause? So here, if I talk about these 3 findings on a cardiotocography, here we will check for uterine contractions and for fetal heart rate. Okay, during uterine contractions, the fetal heart rate should drop. During every uterine contraction, the fetal heart rate drops. This is called as early deceleration or type 1 deceleration, right? Here it is seen in cases of normal pregnancy and it is usually due to head compression and nothing is to be done for this. Type 2 or late deceleration, here you can see the uterine contractions are occurring over here, but after some time the fetal heart rate is dropping. These are called as type 2 or late deceleration. It is usually seen due to placental insufficiency. Okay, it is seen due to placental insufficiency. Okay, whereas variable decelerations, when there is no relation in between the uterine contractions and the decrease in the fetal heart rate. These are called as variable decelerations, which are the most common decelerations overall, and these are due to umbilical cord compression. These are due to umbilical cord compression. Whereas this one, where there is a sinusoidal wave, these are usually seen due to fetal anemia. Okay? So at least remember these three most common ones. So here we can see that there is no relation between the uterine contraction and the fetal heart rate, which is dropping. So it is the most common type of deceleration, which is also called as variable deceleration. And the cause behind it is option B, umbilical cord compression, right? Umbilical, दोबारा image दिखा दूं, ये लो. 28 का आंसर, just a minute, I'll let you know. ठीक है? 28 का आंसर is option A. It should not be increased unconjugated estradiol, rather it should be decreased unconjugated estradiol. Question number 30, guys. Which are the most common type of twins? I hope this is easy for all of you now. Let's see. Twins, 70% of the twins are dizygotic, when two zygotes would be formed from two different ovaries and two sperms would fertilize them, right? So these are also called as non-identical twins or fraternal twins. Whereas if the twins are formed from single zygote, when one ova was fertilized with a single sperm, but then after zygote formation there was division of this zygote, then it is known as a monozygotic, identical or maternal twins, right? So please remember here, if there is a dizygotic twin, the membranes and placenta would be different for both the twins. Okay, and these would be dichorionic diamniotic twins, that is DCDA twins, right? All dizygotic are DCDA twins. First thing. If I talk about monozygotic twins, guys, usually if the cleavage occurs within the first 3 days after zygote formation, if the cleavage occurs within the first 3 days, then that the membranes would be separate and the placenta would be separate. Then there would be formation of DCDA, dichorionic diamniotic twins. If the separation occurs between 3 to 8 days, then there would be two different membranes, but they will share a single placenta. That means a monochorionic diamniotic twin. If the cleavage occurs between 8 to 12 days, then they will share the membranes as well as they will share the placenta. That means a momo twin, that is monochorionic monoamniotic twin. And lastly, if the cleavage occurs after 12 days of fertilization, then there would be a conjoined, also called as a Siamese twins, right? Please remember. So here you can see majority of the twins are dizygotic and all dizygotic twins are dichorionic diamniotic. Whereas 30% of monozygotic twins are also dichorionic diamniotic. So overall, if I ask without mentioning anything, guys, the answer should be option A, dichorionic diamniotic are the most common type of twins. But if I ask you among monozygotic, forget this one, okay? Forget this one. I am only talking about the monozygotic twins. Then out of these, which are the most common? Then your answer would be monochorionic diamniotic, okay? These are the most common among the monozygotic twins. Okay? Overall, DCDA in monozygotic, it is MCDA. No issues with it. If I perform ultrasound in twins, if it is a monochorionic diamniotic, that is an MCDA twin, here in the MCDA twin, you can see the placenta could not go inside between the fetus. Therefore, there is a very thin shadow which is seen. This is known as a T sign, right? Whereas if it is a DCDA twin, in DC, dichorionic diamniotic, the placenta will go between the fetal membranes, and this is called as a lambda sign or a twin peak sign, okay, or a twin peak sign. Important. Moving further. Question number 31 now. It says a patient presented with bleeding per vaginum and amenorrhea. Ultrasound performed has been given below, and chorionic villus sampling reveals genotype of 69XXX. So chorionic villus sampling was done and then karyotyping was done, which shows a genotype of 69XXX. So usually the normal genotype is 46XX or 46XY. That is called as diploid. Here it is 69. That means it is a triploid karyotype. Okay? And likely diagnosis is. So here is the ultrasound image. Bleeding per vaginum, amenorrhea. So amenorrhea, that means likely we will suspect pregnancy in this patient, right? So it is not an ectopic pregnancy because ultrasound shows that there is some mass inside the uterus. Definitely ectopic pregnancy is ruled out. Second option is intrauterine pregnancy. In intrauterine pregnancy, only the fetus would be seen. But here along with fetus, there are some other structures which are seen. So definitely it is also not an intrauterine pregnancy. So the diagnosis over here is actually a molar pregnancy. Molar pregnancy, that is your hydatidiform mole. It can be of two types. Either it is a complete or vesicular mole, or it is a partial mole. I hope all of you are sure that in partial or complete mole, in partial mole, guys, there is presence of a fetus as well as these vesicles which are seen over here. Okay, so if there is presence of fetus as well as vesicles, both of them, then it is a partial mole. Here the diagnosis is more likely a partial mole. First thing. Second diagnosis, it was easy because triploidy or a triple genotype is only seen in cases of partial mole. Whereas in cases of a complete or vesicular mole, the genotype is absolutely normal. That is, it is either a 46XX or a 46XY. So genotype, if it is 46XX or 46XY, with a snowstorm appearance on an ultrasound, and without any fetus, there is no fetus over here, right? Without any fetus, then it is actually a complete or a vesicular mole. But if there is also a fetus in this and even a snowstorm appearance, then it is more likely a partial mole. Okay? So I hope this was easy for all of you now. Definitely it is non-normal pregnancy. Ovarian hyperstimulation syndrome. The ultrasound image came in December. There would be large follicles in the ovaries. This is not ovary. And there would be a history of in vitro fertilization or injection clomiphene citrate, which was given to the patient for induction of ovulation. Okay. How do we manage partial or complete mole? Molar pregnancy is usually managed with, this was important. Yes, very good. It is suction evacuation. It is suction evacuation with a carbon cannula. Important, right? Suction evacuation is performed. And for follow-up, after a suction evacuation, then, okay, after a follow-up, for follow-up, usually we will check the levels of beta HCG. And we will check the levels of beta HCG weekly till at least 3 consecutive samples are negative. Okay, in a partial mole, usually beta HCG levels come back to normal in a period of 7 weeks. Whereas in complete mole, the beta HCG levels would come back to a level, to normal level at around 9 weeks. Okay. So after suction evacuation, beta HCG levels are usually measured in this patient weekly. So partial mole mein it becomes negative around 7 weeks. In complete mole, it becomes negative around 9 weeks. And even after that, we will continue once a month beta HCG level for 6 months. Okay. Because there would be a high risk of choriocarcinoma. As we know, choriocarcinoma is actually a tumor of the syncytial trophoblast, right? It is the tumor of syncytial trophoblast, and it usually follows a partial or a complete mole, right? And that is why we check the beta HCG levels, right? And beta HCG, as we know, it is a tumor marker for choriocarcinoma. Most common site of metastasis of choriocarcinoma is lungs, and management in this condition would be, management in choriocarcinoma is usually methotrexate. In ectopic pregnancy, we were giving single dose methotrexate. Here we will give multiple dose methotrexate. Okay, here we will give multiple dose methotrexate. At least minimum 3 doses are usually given. Very good. 1, 3, 5, 7, 9 days. Great. If you know that, that is well and good. If you don't know that, don't worry. Usually in FMG they don't ask the dates. Question number 32. What is the best time to perform the below given procedure in a patient? So this is definitely, it is easy. That it is a tubectomy procedure when the fallopian tube is ligated for the purpose of sterilization or contraception. It is a single ligation technique, and this single ligation technique, it is more commonly, rather the most common tubectomy technique performed in India, and that is the Pomeroy's technique. The double ligation technique, this one, it is known as the Parkland's technique, whereas when one end of the tube would be buried in the mesosalpinx, the other end would be buried on the uterine wall. This is known as the Irving's procedure. When it is a subserosal dissection is done, subserosal dissection, we will lift up the serosa and will cut the tube and again will suture the serosa back again. This is known as the Uchida's procedure. And can anybody tell me the best chances of reanastomosis after a tubectomy procedure is seen with which method? Best chances of reanastomosis and worst chances of reanastomosis. Best chances of reanastomosis are seen after, they are seen usually after applying laparoscopic clips or laparoscopic ricks of bands, because we can just remove this and the tube is absolutely normal after that. So best reanastomosis is seen after clips or bands, whereas worst reanastomosis chances are usually seen with cauterization, because you will burn the tube. Okay. Whereas Assure ring, this is a Assure ring which is inserted into a fallopian tube. It is made up of which alloy? So this alloy has been asked earlier. Assure ring is made up of which alloy? and it usually takes 3 months for its action. It causes fibrosis of the fallopian tube. Assure ring is made up of nickel alloy. That means it is made up of nitinol. Please remember, it is made up of nitinol. Very good, very good. So here, definitely it is a Pomeroy's technique which is performed. So what is the best time they are asking to perform the below given procedure in a patient? Option A says at the time of vaginal delivery. So if you are performing a vaginal delivery, why would you cut a patient again? If it was cesarean, definitely it was understood that subsequent or concurrent tubectomy can be performed in that case, not in vaginal delivery. Within 2 to 3 days of delivery, yes, this is the best answer. Why? Because within 2 to 3 days of delivery, the uterus is still an abdominal organ and it is easily accessible. So that is the best time where you can easily approach the fallopian tubes and then ligate it. Okay. Whereas maximum it can be performed up till 7 to 10 days. But after 10 days, uterus becomes a pelvic organ and it is hard to approach the fallopian tubes over there. Okay. So after 7 to 10 days, usually after 7 to 10 days of delivery, it is not recommended to perform tubectomy. Maximum you can perform within 7 to 10 days, but the best time if they ask you, the answer should be within 2 to 3 days after delivery. After 6 weeks of delivery, that means usually after your purpurium, it can be performed, but again, it is a pelvic organ, so it becomes difficult. Best time, if they have given cesarean section at the time of delivery. If they are saying that the patient is having a cesarean section at the time of delivery, because you are anyways opening the abdomen. Question number 33. When is the cardiac output maximum? This question has been repeated multiple times. When is the cardiac output maximum in a pregnant female? Okay, they are not asking you about the antenatal period. If they would have asked you about the antenatal period, then you would have only said about pregnancy. So they are only asking in a pregnant female. So the best answer to this would be option B, third stage of labor. As you can see in this image, guys. Okay, this purple one, immediate postpartum. Sometimes it can be also given as immediate postpartum. That means immediately after the delivery of baby or immediately after the delivery of the fetus. In the third stage of labor, the cardiac output reaches maximum to almost 9.3, right? Whereas the second best answer would be second stage of labor during the delivery of baby. It is almost 8.9. The third best answer would be early second stage of labor, but they usually don't give this one. And if they ask you during antenatal period or during pregnancy, the best answer you can see it is maximum. That means between 28 to 32 weeks of pregnancy. If you need to choose one, the single best answer should be 32 weeks of pregnancy. So if they ask you during antenatal period or during pregnancy, maximum cardiac output is seen during 32 weeks. If they ask you overall, the best answer would be immediate postpartum or third stage of labor followed by second stage of labor. Okay? No issues with this. Question number 34. A patient was 36 weeks pregnant and presented to you in labor in the labor room. Her history tells that she is on warfarin therapy. What is the next step in the management? So now this question has been repeated in Fmg also, in ICT also, and even in NEET PG also. Okay? But I have just modified it somewhat. Okay? Pregnant female, they have said, not in pregnancy. Please remember. Okay? So guys, please, excuse me. So guys, please remember, if they would have just mentioned that the patient is pregnant and she's on warfarin therapy, what should be done, which was the question in all these exams, the answer would definitely have been stop warfarin and start heparin. Because as we know, warfarin is a teratogenic drug. It causes fetal warfarin syndrome. Therefore, we will stop warfarin and start heparin. But here, please remember, they have given a very important condition that she presented with labor. So there is an ongoing labor. If you stop warfarin at this point of time, there would be excessive risk of more bleeding in this patient. So if the patient is in labor, definitely that is not an indication to stop warfarin or start any other drug for that matter. Okay, so option A and B can be ruled out. Anyways, normal vaginal delivery is not recommended if a patient is on some anticoagulant therapy, because if she's on some anticoagulant therapy and that is not stopped, and if you perform a normal vaginal delivery, there would be high chances of postpartum hemorrhage in this patient, right? So normal vaginal delivery is avoided, rather a cesarean section is done. So definitely we will continue warfarin but not perform a normal vaginal delivery. Rather, we will continue warfarin and perform a cesarean section because they have said that the patient is in labor. If they would have just mentioned pregnancy, then our answer would have been stop warfarin and start heparin. Okay? No issues with this? I'm relaxing, don't worry. Question number 35 says, a patient, I'm actually worried about the time only. Question number 35 says a patient had a first pregnancy at pregnancy loss at 8 weeks. That means a first trimester abortion was there, right? First trimester abortion. Then second pregnancy loss at 11 weeks. Again a second first trimester abortion is again with no cardiac activity. And the third, preterm delivery due to early onset preeclampsia. What is the underlying cause? Okay. नहीं मैं घर पे ही उठना है. Don't worry. A patient had first pregnancy loss in first trimester, then second pregnancy loss again in first trimester. So there are 2 pregnancy losses in the first trimester, right? Apart from that, there is one preterm delivery, and this preterm delivery is due to early onset preeclampsia in this patient. So this, okay, preterm delivery due to preeclampsia. I hope all of you are quite aware. This is the clinical criteria to diagnose. Yes, very good. This is the clinical criteria to diagnose APLA, that is anti-phospholipid antibody syndrome. Along with that, we also need one clinical feature and one lab feature. Okay, and lab feature is what? Presence of antibodies, because it is an autoimmune condition. So which antibodies would be present? Anti-cardiolipin antibody is present. Anti-cardiolipin antibody. Then lupus anticoagulants are present. Lupus anticoagulants would be present. Along with that, the most important, if they ask you single best, then your answer should be anybody. This was the question. Single best antibody or the most specific antibody in APLA syndrome. Answer should be anti-beta-2 glycoprotein, sometimes also referred to as anti-beta-2 microglobulin antibody. Please remember, this is the most specific antibody for APLA syndrome. Okay? So this diagnosis is definitely anti-phospholipid antibody syndrome, where there are recurrent abortions in the first trimester less than 10 weeks, or there's a preterm delivery due to preeclampsia and presence of all these antibodies. Okay? Septate uterus, as we know, it causes second trimester abortion. Gestational diabetes mellitus does not lead to abortions. TORCH, important. TORCH will lead to a single abortion. Why? It will not cause recurrent pregnancy loss. TORCH cannot be a cause of recurrent pregnancy loss. Please remember, because once if the patient has some infection, toxoplasmosis, others like syphilis, rubella, cytomegalovirus, and herpes, these are TORCH infections during pregnancy. If the mother gets the TORCH infection once, she gets a lifetime immunity for that particular infection, right? She gets a lifetime immunity. Therefore, TORCH can be a cause of abortion only single time. Multiple pregnancy losses are not associated with TORCH. Question number 37, guys. A woman on oral contraceptive pills missed her periods. Her LMP was 6 weeks back. How will you know the accurate gestational age? 6 weeks back, that means she is having 6 weeks of amenorrhea. That means even though if she is pregnant, it would be the first trimester of the pregnancy. So which is the best thing to diagnose her gestational age? So option A says subtract 3 months and add 7 days to LMP. It is the Nagar's rule used for expected date of delivery, guys, not for gestational age, right? It tells you about the expected date of delivery. LMP is last menstrual period. Okay. So it is for expected date of delivery that we already discussed, Nagar's formula, right? Then option D says assess the fetal fundal height. Fundal height definitely can give you a fetal age, but it is actually a estimated fetal age. Okay, it is estimated, or we can say tukka hai hota hai wo. Okay, you can say, okay, if this is the fundal height, maybe this is the week of pregnancy. But sometimes there can be a twin pregnancy, there can be a large baby, so it is not so accurate. Definitely can be ruled out. Option B says measure the crown rump length on ultrasound. Definitely it is the method of choice for measuring accurate gestational age during the first trimester of pregnancy. So if they ask you for fetal age estimation, which are the parameters which you will check on ultrasound? So in the first trimester, the best parameter used is the crown rump length. In second trimester, the best parameter used is the BPD, that is your biparietal diameter, right? Whereas in the third trimester, the best parameter used is the femoral length. Whereas one more parameter is used, that is abdominal circumference. If it is less than 35 centimeter, it is suggestive of IUGR in the baby. Okay? So these are the important things that you need to remember. Okay? So here it is first trimester, therefore measuring CRL on ultrasound would give us the accurate gestational age in this patient. Question number 38. Pregnant lady went into labor. At term, the baby had a breech presentation as shown. So this is the breech presentation, and she was taken for a normal vaginal delivery. The buttocks of the baby were delivered. All the below given manures would be employed for the delivery, except for which manure would not be performed, right? So these are the three types of breech presentation. First is a frank breech. Okay, as I told you, it is the most common type of breech, also called as the extended breech, guys, right? Where the lower limbs are extended, but the upper limbs are flexed. Whereas next is the complete breech, also called as the flexed breech, where all the four limbs are flexed. And third is the footling breech, right? As we know, in footling breech, we will always and always perform a cesarean section. Whereas in frank and flexed breech, we can deliver this child even with the help of normal vaginal delivery. So here we can see it is an extended breech or a frank breech. Therefore, we can deliver this child with the help of a normal vaginal delivery. So she was taken for an NVD. The buttocks of the child had been delivered. What are the all the given below manures would be performed except for? So let's see one by one. Option A says, I'll show you the images that would be better. Okay. This is the Pinard's manure, guys. So Pinard's manure is when you will press on the knee and will deliver the extended legs. Our child is having extended legs, definitely. So Pinard's manure would be performed in this child, right? Next is this Lovset's manure. Okay, this is the Lovset's manure. It is usually done for extended arms. Okay, so extended arms may usually you will grab the arms by the elbow and pull it down. Okay, so this is the Lovset's manure. Here our child is not having extended arms, so Lovset's manure is of no use. Okay, whereas if I talk about the aftercoming head, the safest procedure for delivering an aftercoming head in a breech presentation is these Piper's forceps. Okay, these Piper's forceps can be applied. Okay, so they can be used. Apart from that, please remember, we can also use this Mauricio smelly Viat manure. This is also called as shoulder traction and jaw flexion. Okay, we will apply a shoulder traction and the jaw or malar flexion would be performed. This is known as Mauricio smelly Viat manure. Whereas the last manure is a Burns Marshall manure, where you will let the child deliver almost till the chest or umbilicus, and then you will hold the legs of the child and turn it in a 360 degree, and therefore the head will pop out. This is known as the Burns Marshall manure. Okay, that is the easiest one, I hope so. So here, Piper's forceps definitely will apply for the aftercoming head. Burns Marshall manure can be used for the aftercoming head. Pinard's manure for the extended legs will require it, but Lovset's manure, as the baby is not having extended arms, so will not require Lovset's manure to be performed. Question number 39. A patient is taken up for a normal vaginal delivery who was in labor. The child has vertex presentation, but position is occipito-posterior. So I hope all of you are quite aware. The most common presentation is usually cephalic presentation, and in cephalic they ask you the most common position. Then the most common position is usually left occipito-transverse followed by left occipito-anterior. That means the occiput should be anterior or it should be transverse, right? But here they are saying the occiput is posterior. That means the face is coming in front. Okay, so which among the following is not a risk factor for occipito-posterior position? So these are the four types of pelvis. The most common or the female type of pelvis that we have, where there would be a round shaped pelvic inlet. This is known as a gynecoid pelvis. Next is the android pelvis. Okay, where there is a heart shaped pelvic inlet, also called as the male pelvis. It is known as the android pelvis. Next is anthropoid pelvis. Here you can have a oval pelvic inlet. Okay, if there is an oval pelvic inlet, it is anthropoid pelvis. And if it is a flat pelvic inlet, it is called as a platypelloid pelvis. Okay? So please remember, if I talk about occipito-posterior position, right? So that means, okay, so please remember, this is the, I don't think so you will be able to see this bottle as such. Okay, yeah, so this is the face of the child. Okay, so the face of the child is being delivered like this. This is the occipito-posterior position. But what happens, usually this face will rotate. Okay, the position will rotate and the child will become occipito-anterior. Okay, the child will become occipito-anterior and deliver in 80% of the cases. But in some conditions, due to some deformities, what happens, this position or the occipito-posterior, it cannot be rotated. Why? First of all, in android pelvis, as it is an oval cavity, the child cannot go beyond this. Okay, so there would be a persistent occipito-posterior. Okay, so please remember, in anthropoid pelvis, there is a risk of persistent occipito-posterior. The child's head could not rotate even 30 degrees. Whereas in cases of android pelvis, okay, in cases of android pelvis, this is a heart-shaped pelvis, the head could rotate up to some extent. That is, it would rotate up to some extent at till 30 to 45 degrees and then it will get arrested. So this is actually called as a deep transverse arrest. So there would be a risk of deep transverse arrest in cases of android pelvis. If there is a deflexed head, so normally the child has a flexed head. If it is a deflexed or extended head, again it could not be rotated properly. But if it is a platypelvoid pelvis, that is not a risk factor for occipital-posterior position. Okay, please remember this. Android, anthropoid, and deflexed head are all risk factors for occipital-posterior position. Anthropoid will lead to persistent occipital-posterior. If the child is not delivered,